कॉल मारू Rabbi.
ଚପଲ କିଣିବୁ ହେଲା, ଚପଲ କିଣିବୁ। ଗୋଟେ ମିଟିଂ ଅଛି, ସେଥିପାଇଁ କହିଲେ ଥାଉ ମୁଁ ପଳଉଛି। ରଖିଦେଇଛି।
ବନ୍ଦ କର, କବାଟଟା ଆଉଜି ଦେଇଯିବ।
कैमरा तो ऑन नहीं हुआ। रिकॉर्ड हो रहा है एक्चुअली। आप है ना, आपका नाम शो करेगा।
So how does I have loaded only the BAM file. Now I'm loading the VCF file as well for the same case. Right? So now I have loaded VCF file. So this is my VCF file.
So on the eve of Azadi Ka Amrit Mahotsav, with the blessings of the Almighty and encouragement and support from our Dean and Principal Madam, Academic Dean Madam, and with enthusiasm of all the participants and consent from all the esteemed panelists and the esteemed speakers, my department staffs and friends, family, and Dr. Chinmay, who has given us this digital platform to begin this virtual meeting. We are about to start this meeting. So now I invite our esteemed Dean and Principal Madam, Professor Dr. Sabita Mahapatra, to deliver her welcome address. Madam has been a guiding force all through. So, Madam, I welcome you to give your address. Please, Madam, do the honor.
Thank you, Dr. Sucharita. Good afternoon, all. It's my proud privilege today to welcome you all to the CME on Immunological Response in COVID-19, organized by the Department of Biochemistry of Bhimabhoi Medical College and Hospital, Balangir, Orissa. So I congratulate Dr. Sucharita Mahanti for incepting this idea, which is most important at this time when we are in between the first and second waves, avokes, overgone, and yet to face the third wave, which is going to hit anytime very soon. Now, this topic is very important because, as we know, when we are grappling through the pandemic, one thing was very unknown to us as to who would suffer the most. That is, there were 3 stages of the disease: the mild, moderate, and the severe. And the severe instances were taking away the life of the individuals. And we did not know who would be the victim of this pandemic. So it was one criteria which decided who would go into the severe stage and land up with cytokine storm and acute respiratory distress syndrome and multi-organ failure leading to death. The only one criteria was the immune status of the individual while facing the virus. Now, this immune response to the virus, which was supposed to be protective, was in the end becoming damaging, and it was the only factor which decided the progression of the disease in the individual, the prognosis of the disease in the person, and the diagnostic markers which needed to be in place so that we can diagnose the stage of the disease in the person, as well as devise treatments to handle the immunological havoc caused in the individual, as well as decide for the vaccines that need to be created. Now, as an administrator, we were fighting tooth and nail to handle these severe cases who were in the cytokine storm, who needed oxygen every minute to survive. And with the number of oxygen cylinders available with us and the oxygen concentrators available with us.
Principal, Balangir principal.
So, can I continue?
Yes, Madam.
So, we could not make both the ends meet, the demand and the supply of oxygen, just because of the immunological crisis in the individual happening. And we had to hold midnight meetings. We would sit for meetings from night 11 o'clock and keep awake the whole night till morning 6 to see that we had that amount of oxygen that was needed to keep the patients alive in a hospital for the next morning. So for this, now it's the right time for us to know more about the real nature of the virus, the immune system, immune response to the infection, the vaccines that are created as per the immunology of the virus, and the post-vaccine immunity that we have gained after the vaccination. Now, to discuss about all this, we have very eminent speakers of national repute with us. I welcome Dr. V. Ravi, the Nodal Officer for Genomic Sequencing of SARS-CoV-2 in the government of Karnataka, who has founded the Department of Neurovirology at NIMHANS in 1985 and has worked there as professor and head of the department and later as the registrar and dean of the institute NIMHANS at Bangalore. I welcome you, sir. Next, I welcome the eminent speaker, Dr. Satyajit Ratha, honorary faculty of Indian Institute of Science, Education and Research at Pune. He is a retired scientist of National Institute of Immunology at New Delhi, and he will be speaking on the immune response in COVID-19. I welcome you, sir. Our next speaker is Dr. Akita Nanda, Professor, Department of Biochemistry, AIMS, Bhubaneswar. She was our workmate at SC Medical College, Cuttack. I welcome you, and I look forward to hear from you COVID-19 and the pancreas. We also have with us Dr. Ira Praharaj, Scientist E, ICMR, RMRC, Bhubaneswar, who was priorly working as Associate Professor in CMC, Vellore. I welcome you to speak on the immunological mechanisms of vaccine-induced protection against COVID-19. And finally, we have a very eminent speaker, Padma Shri Dr. R.R. Gangakhedkar, who is Dr. C.G. Pandit, National Chair, ICMR. He is former head of Division of Epidemiology and Communicable Diseases of ICMR, New Delhi, and director of NARI, Pune. He'll be speaking on the development of immunity post-vaccination, whether we need a booster dose or not, or can we take a combination of vaccines, which is now the talk of the hour. We also have two cream panelists with us, Professor Dr. Pramila Mishra, retired professor and HOD, MKCG Medical College, Parampur, Orissa, who is known for her admiring personality and also as a very prolific academician. She has been our senior colleague for long, and I respect you from the core of my heart. Having known you so well, I welcome you to handle the questions raised by the participants. And I also welcome our other panelist, Dr. Sanghamitra Pati, Director of RMRC, Bhubaneswar, who is well known for a dynamic research handled in the state and the country, and who has been able to make us come out victorious while facing the clutches of this COVID pandemic. I welcome you, madam, to be with us, and I thank you to be there with us to drive us through this session today. Finally, I wholeheartedly welcome all the participants who have joined online in the CME and hope there is great learning ahead, and by your questions and answers and deliberations, we can really understand what lies underneath this strange pandemic which has just crippled the state and the country and has yet not left us free. So thank you all, welcoming you all. I request the moderator to take us ahead with the speakers. Thank you.
Thank you, madam, for such an welcome address. Now I welcome our panelist, Professor Dr. Pramila Kumari Misra and Professor Sanghamitra Pati madam to take the chair. And now I'm going to introduce the first speaker, who is trained as a doctor, but later he was trained to be a immunologist. So till date, formed that the virus, that is SARS-CoV-2, causing COVID-19, mainly spreads through the respiratory tract with lymphopenia and cytokine storms occurring in subjects with severe disease. This suggests that there is definitely some dysregulation that accompanies these patients with moderate to severe disease. So, an early recognition of this immunological phenotype has assisted in prompt recognition of the patients who would likely to progress to severe disease. So, how the immune system responds to COVID-19? Let us enrich our knowledge regarding this from Dr. Satyajit Rath, who is an adjunct faculty of IJR Pune, THSTI Faridabad, CMC Vellore. He is also an advisor of Diabetes Unit, KEM Hospital Research Center, Pune. I welcome you, sir, to present your topic.
Thank you very much. It's a pleasure to be here, and since we have half an hour to talk about the immune response in COVID-19, let me get into it without further ado, with only one apology to make. I don't do very well with slides. I don't do very well with slides, and therefore I'm afraid that you're going to have to deal with the audio only for this particular talk. I'm sure everybody else will make up for the defect. So let me start right away with COVID-19 and immune responses in COVID-19. So when we think about immune responses in COVID-19, we think about them in broadly two categories. One is the immune responses to the virus, and the other is immune responses to the vaccine. So Drs. Ira Praharaj and Dr. Raman Gangakhetkar will, of course, be dealing far more knowledgeably with immune responses to vaccine. So I'm really going to talk about immune responses to the virus. Now, when we talk about immune responses to the virus in COVID-19, we're really talking about immune responses relevant for two overlapping but different outcomes. And those two overlapping but different outcomes is some level of successful virus growth and transmission. And by transmission, I mean growth in the body of the individual infected. And by transmission, I mean person-to-person transmission on the one hand, and signs and symptoms of illness and disease on the other hand. Quite frequently, we tend to treat these two as the same. And while they are overlapping and causally related, they are clearly not the same. And we need to be aware that there are fundamental features that distinguish considerations of transmission from considerations of disease. And I'll come to them as we go along. So before we begin talking about immune responses, and really I'm going to walk you through, walk all of us, reminding myself as well, through what happens when the virus lands somewhere in the respiratory tract and begins its life cycle. But before we begin talking about the immune responses involved, let me make a few points about sort of pre-immune issues related to virus entry that are, I think, deeply relevant to understanding both the pathophysiology of the disease and even more, as ma'am said just a little while back, the great diversity of morbidity trajectories that infection leads to. I simply, as a matter of reminding everybody, it still remains true that by and large, more than 50% of infected individuals have either no symptoms or very mild and very transient clinical symptoms. A very small proportion have moderate symptoms, and a similarly small proportion have these moderate symptoms and signs that are severe enough to need hospitalization. And that's where, as ma'am pointed out, we land up in healthcare delivery system related difficulties when simultaneously large numbers of patients get into this. However, let's remember that there are clear differences between the three major members of the coronavirus family that we've encountered in this century. We encountered the virus responsible for SARS, the coronavirus responsible for SARS 20 years ago. We encountered the coronavirus responsible for MERS 10 years ago. And we are currently in the pandemic for the coronavirus causing COVID. Both the SARS and the MERS viruses appear to be much more lethal at the individual level than SARS-CoV-2 seems to be. SARS-CoV-2, SARS-CoV-2, whatever you want to pronounce it as. Keep in mind that infection fatality rates for both SARS and MERS are far in excess of 10%. I'm not going to quibble about exact numbers. Whereas infection fatality rates for COVID-19 are certainly in the below 1% category. So the sheer uniformity of lethality is quite different between SARS and MERS on the one hand and COVID-19 on the other hand. And that needs to be kept in mind. What that creates is this potential and reality of extraordinary diversity of clinical trajectories post-infection, and features that may serve as contributory factors for this diversity of clinical trajectories, therefore become extremely important in COVID-19. There are common immune interaction issues to all of these coronavirus family members that I'll come to in a minute. But first of all, let's get a couple of obvious points on the table that, for reasons that I'm never quite sure of, we all seem to overlook. First of all, for COVID-19, for a number of other viruses, particularly respiratory viruses, but certainly for COVID-19, there is now substantial, albeit fragmentary evidence that the exposure dosage of virus is a major contributor to the clinical severity of outcome. In other words, how much of a virus dose were you exposed to becomes a relevant issue in determining the likelihood of your developing symptomatic versus asymptomatic infection, and even in symptomatic infection, severe versus moderate infection. I think that this is poorly remembered. As you would imagine, exposure dosage can vary quite widely. If you have exposure dosage, imagine yourself in a scenario outdoors versus in a scenario indoors, especially an indoor scenario with recirculating air, with very inadequate filtration for the system, so that aerosol particles will recirculate through the air supply. That's going to form a very large bolus. But connected to that is the other point underlying emergent pathophysiology that I think we need to remember, and that I think we keep forgetting. And that is, when we talk about respiratory transmission of viral infections, we sometimes, especially in public domain, talk as if an infected individual releases a cloud of 30, 40, 50 nanometer virus particles, individual virus particles, that sort of go in as an individual virion suspension. And that is far from the case. The reality, the mundane reality, is that what comes out as the modality of transmission is droplets. The droplets can be of various sizes. So depending on what the size is, you can call them droplets, you can call them aerosols, whatever you call them. The fact of the matter is that they're all fluid droplets ranging from very large, 10, 15 micrometer or even larger droplets, to really, really small micrometer or even submicrometer droplets. And under those circumstances, what we need to remember is that each droplet has two variables involved in it. One variable is what is the size of the droplet, and the size of the droplet from the same individual will determine what the virus particle number associated with the droplet is. So here are two situations. If I have one droplet coming out of my mouth versus I have one large droplet coming out of my mouth versus I have 1,000 small droplets coming out of my mouth, that's in totality, the amount of virus-laden fluid is the same. In totality, therefore, the virus dosage may be the same, but the efficiency, two things vary. One is the efficiency with which these droplets will go into somebody else's airways. But even more importantly, perhaps, the fact that one droplet, when it goes, one large droplet, when it goes in, is likely going to lodge into the nasal cavity or in the nasopharynx or at most the upper airways in one microanatomical location. Whereas 1,000 droplets, all of which may not land in any meaningful fashion, but will go to different locations in the anatomy of the respiratory system and will go to many more locations. And I think that this is a fundamental feature of the obvious, simple notion of infection transmission that we forget when we try to explain the heterogeneity of clinical trajectories of morbidity. So that's really a major point that I will come back to as I begin talking more and more about the actual immune response. The third point I want to make about, in addition to exposure dosage and droplet aerosol related issues, is cell surface receptors for the virus. So we're all treating angiotensin converting enzyme 2 ACE2 as the cell surface receptor through which SARS-CoV-2, the virus, enters cells. And this is not, of course, inaccurate. It's quite correct as far as it goes. There are three issues to be kept in mind about this. The first is that ACE2 levels on cell lineages, on tissues and cell lineages of the body, vary quantitatively, number one. And number two, all cell lineages do not necessarily express ACE2. So the levels, the availability and the level of ACE2 is going to contribute yet another contributory factor that will begin to determine how much diversity to the clinical morbidity trajectory there is. Let me give you a very simple example. So long as the virus is confined to the respiratory system, we are talking about a handful of cell lineages in the respiratory system that will express ACE2 and that are therefore liable to be infected. There are all sorts of oddities about this, but let me not get into those for the moment. But if inflammatory containment in the respiratory system begins to break down, then we have the virus coming out of the respiratory system into larger circulation. In moderate to severe COVID-19, fragmentary evidence is that anything between, I think, about 5% to about 20% of people show viremia in the blood at some point. And once you have that, you have a situation where the virus can potentially infect a large number of specialized tissue lineages across the body. It can infect endocrine lineages, it can infect gut epithelial lineages, it can infect neuronal lineages, it can infect exocrine gland lineages. And in all of this, therefore, the possibility of forming niduses, foci of viral infection in a whole range of other tissues, with subsequent modulation of the clinical trajectory of the morbidity, begins to raise its head. And therefore, I think that the cell surface receptor diversity needs to be kept in mind. The second point about cell surface receptor diversity issues is that there have been, again, very fragmentary evidence in addition to ACE2 of other cell surface molecules mediating function as SARS-CoV-2 virus receptors. The most frequently brought up one in this context is CD147, also known as Besigan, which was shown, and since it has for other clinical reasons a monoclonal antibody against it, people were trying to use an anti-Besigan antibody for interventions. There has been a fair amount of controversy about whether the Besigan CD147 functionality as a SARS-CoV-2 receptor is real or not, and the matter still hangs in the air unresolved. But clearly, there is evidence, and this is my last pre-immune point, there is evidence that there are ACE2 independent pathways of virus entry into cells. This is particularly true for cells of the immune system, such as macrophages, such as dendritic cells, many of which do not necessarily express at some stages in their differentiation trajectory. They don't necessarily express ACE2, and yet they can take up virus. And in the case of dendritic cells, there is evidence that they can not only take up virus, they can transfer virus in functional anatomical locations from one location to another, and they can actually, because they come into close contact with cells in the lymphoid environment, they can actually transfer virus into a productively infection susceptible lineage such as endothelial cells. So all of this, exposure dosage, the droplet issue, and therefore the functional anatomy issue, and the cell surface receptor and the cell entry issue begin to provide the background landscape to beginning to explain the pathophysiology of the clinical diversity of morbidity trajectories insofar as COVID-19 is concerned. So with that, let me talk about the immune responses in SARS-CoV-2 infection. And let me start with what we expect immune response outcomes to be. And then I'll say something about the actual immune responses. So keep in mind that there are two separate categories of immune response outcomes involved. Remember what I said, that we have a droplet coming. So I have a droplet from an infected individual. Droplet is laden. It carries, to use ISRO speak, it carries a payload of virus particles, and it lands somewhere in my nasopharynx or in my pharynx or in my trachea. It lands in one place. It's a droplet. So it's in that place that the successful virions, the successful virus particles, which can sink through the mucus and actually attach to ACE2 molecules on the surface of, say, pharyngeal or tracheal epithelial cells, begin to infect target cells. Now, as a consequence, the immune responses begin locally at the point at which virus-mediated immune triggering happens. And this is a fundamental feature of the immune system, indeed, not simply immune responses, that we tend to forget. And a consequence of this is the massive and, to my eyes, fraudulent market in immunity boosters out there that we've seen over the past year and a half. You don't want cells of the immune system activated unless they are actually triggered by a target. And if they are triggered by a target, then you actually want them to be functional in the microanatomical location where the target is available. You don't want them to go away somewhere and do something there. And I hope people can see that if cells of the immune system begin to do that, then what you end up having is far more systemic consequences, such as cytokine storm, such as multi-organ failure, and so on and so forth. So we therefore, from this locally sourced triggering of the immune system, the two immune response outcomes we really want is, one is prevention of virus growth. And we prevent virus growth in two distinct ways, by two distinct pathways. One is we make cellular biochemistry far more resistant to viral RNA entry and viral RNA mediated takeover of cellular transcriptional and translational machinery for virion assembly. And we do that by and large through the type 1 interferon pathway. Please keep in mind that the type 1 interferons, type 1 and type 3 interferons together constitute some between 15 to 20 different molecules. So it's a very diverse set of signaling molecules that we call the type 1 interferon pathway. But the type 1 interferon pathway triggers this viral resistance in potential target cells, and that's one limitation of virus growth. A second limitation that the immune response puts on virus growth is actually identifying virus-infected cells, preferably before virion assembly in the infected cell begins, and beginning to kill infected cells by inducing programmed cell death, by and large, in them. And this is done broadly. There are, again, a number of ancillary pathways that mediate this, but broadly, we've got two distinct cellular effector immune pathways that mediate this. One belongs to the innate immune category, namely the natural killer cells, and the other to the adaptive immune category, namely the CD8 cytotoxic T cell responses. Both of these, the interferon activation mediated limitation of virus growth, and even more, the killing of target cells is likely to create a pool of dead, dying cells at the location of infection. So what we are really doing is, we have a good outcome, which is limiting virus growth and virus load. But we have a problem that is created as an inevitable consequence of the good outcome, which is cellular debris that needs to be dealt with in some fashion. Because if it's not dealt with, then we are going to have consequences upon cellular debris, because as cellular debris begins to accumulate, it provides damage-mediated signaling, and damage-mediated signaling will cause a whole separate set of difficulties for us. But over and above simply reducing virus growth, we have a second component of immune response outcome that's absolutely crucial, and whose purpose I sometimes think we in the biomedical sciences seem to forget. And that is, remember that the virus has landed in one place, and therefore there is already, at the point of initiation, a microanatomical localization. It is to the advantage of the host body not to let the virus spread into the rest of the body from this location. This is a localization function that's independent of the number control function. And this localization function is mediated by what all of us refer to so cavalierly and casually as inflammatory pathways. So inflammation is a modality for creating what all of us are very familiar with over the past year and a half, creating microcontainment zones. And it is this microcontainment zone creation that provides contained infection status, which is to the advantage of the infected individual, but it also creates consequences. And that's the other side of the coin. That as a consequence of killing virus-infected cells, as a consequence of creating inflammation, mediating both containment of the infection at the initial locus, as also mediating the recruitment of cells of the immune system, immunocytes, let me call them, into this location for functionality for achieving virus growth control. What we are creating is, number one, we are creating cell and tissue damage because of this inflammation and cell death. And what that is leading to is local tissue dysfunction. This is admittedly local tissue dysfunction. And this is where, depending on whether you have this local tissue dysfunction due to inflammation in a handful of locations in the respiratory system versus in 500 different locations of the respiratory system, may well begin to mark the beginnings of a divergent trajectory of clinical morbidity. And this is something that I think it's absolutely crucial for us in the biomedical sciences to remember as the basis, as a contributor to the diversity of clinical trajectories that ma'am referred to right at the beginning. Let's also keep in mind that the fundamental function of cytokines, all cytokines, absolutely all cytokines, are distinguished from hormones by the fact that hormones have long radii of action, cytokines have extremely short radii of action. All cytokines have a short radius of action. There are a couple of exceptions, but they basically simply go to prove the rule. So the fact that microanatomical locations of inflammation create these contained inflammatory spots actually points out that cytokines are made there and function there. But inevitably, since they are aqueous phase molecules, since they have to diffuse and signal from one cell to another, there is always a certain amount of overflow. Depending on how many sites of inflammation there are, by and large, overflow concentrations of cytokines from contained locations into systemic circulation are not sufficient to initiate systemic signaling downstream of cytokine receptors. But if you have a sufficiently large number of inflammatory locations that are active for a sufficiently long period of time, then you are going to begin to have the overflow of cytokines from just regular, ordinary inflammatory locations achieving threshold levels in systemic circulation. And if they achieve threshold levels in systemic circulation, then what they initiate is pathogen and location disconnected inflammatory signaling. And that is what all of us begin to refer to as a cytokine storm. That's what all of us begin to refer to as endotoxemia. That's what all of us begin to refer to as sepsis in the broadest term. And that is what eventually begins to contribute to the clinical outcome of multi-organ failure. So those are the base features of what I'm calling the contributory factors to the diversity of clinical outcomes. Let me make one more layer of comments about the molecular pathways involved in this diversification. As you can imagine, the earliest local immune responses that get triggered are type 1 interferons, inflammatory cytokines, and NK cells. And type 1 interferons and NK cells will provide the early crucial control over the virus growth. Now, keep in mind that SARS-CoV-2 is a virus that is not horrendously morbid. Number one. Number two, the clinical virology trajectory of infection is that long before symptoms arise, most infected individuals are already growing the virus and are transmission competent. Which means that we should really have the expectation that SARS-CoV-2 has some way of slightly delaying these early innate immune responses. And indeed, members of the coronavirus family, many members of the coronavirus family use non-structural proteins to signal interruptions to the type 1 interferon pathway. I'm not getting into the details of which ORFs do what and so on and so forth. There's still fragmentary evidence about this. But clearly, the virus for SARS, the virus for MERS, and the virus for COVID-19 all have non-structural proteins in their genomes which have the potential to interrupt type 1 interferon pathways. So this is simply a delaying tactic for the virus. Or more correctly, that's what happens. You have a delay. This delay is sufficient to provide the pre-symptomatic transmission state that allows the virus to spread. In a disease ecology sense, that's sufficient for the virus population to keep growing in communities of host individuals. But what that does is it creates a point of susceptibility. If the virus is already delaying type 1 interferon pathways a little bit, keep in mind that type 1 interferon pathways are also substantial activators of natural killer cells. Also keep in mind that both the type 1 interferon pathway and the natural killer cell are major producers downstream of inflammatory cytokines, and not simply inflammatory cytokines, of immunomodulatory cytokines that shape, influence the downstream adaptive CD4, CD8, T cell and B cell responses. So what happens early on has major consequences going forward. And it is at this point, therefore, that you begin to imagine that any further additional very small compromising of an individual's type 1 interferon and NK cell pathway competence might tip the balance from simply delaying type 1 and early innate immune responses so as to let the virus establish infection, transmit, give us a mild clinical syndrome and overcome it, into allowing the virus to spread quite substantially and tipping the clinical situation over into moderate severe COVID-19. So that's sort of an obvious speculation that we can make. And in a minute, I will point out that there is some emerging evidence in support of this. But before I do that, let me simply formally state the components of the adaptive immune system. Everybody points out that the innate system is early, the adaptive system is late. This is, the difference is not that large. Typically, after viral infections, type 1 interferon path level peaks come at about 10 to 12 hours. By between 36 to 48 hours, you already begin to detect cytotoxic CD8 T cell responses in viral infections. So the gap between the early innate immune response and the late adaptive immune response is not that enormous. So the first adaptive immune responses that you typically find are CD8 T cell responses, which is not surprising. They will be very useful. You find a conjoint emergence of T-dependent B cell responses and CD4 T cell responses. Remember that all of these adaptive immune responses, unlike the innate immune responses which are taking place in the microenvironment at the site of infection, all of these adaptive immune responses are taking place in the draining lymph nodes. So depending on whether you have the nasal cavities and nasopharynx or oropharynx or the tracheobronchial tree infected, the draining lymph nodes will vary, and therefore the site of adaptive immune reactions will vary. CD8 and CD4 and B cell responses work with each other, but CD4 T cell responses have a number of different trajectories. Everybody has by now heard of Th1, Th17, Th9, Th2, T follicular helper responses. The two major distinctions in CD4 T cell responses is, one is those CD4 T cell, effector CD4 T cells that help B cells. The distinction is they carry out their function in the lymph node, because the B cell responses are also going on in exactly the same lymph node. So T follicular helper cells don't need to leave the lymph node in order to carry out their functionality. They simply need to move from one microanatomical location in the lymph node to another. Whereas the inflammatory T cell responses, Th1, Th17, Th9, or even Th2, which gives rise to a different configuration of inflammation, have to leave the draining lymph nodes, come into general circulation, and then be selectively retained in the site of infection in order to do this. The last point about B cell responses is antibodies, neutralization, non-neutralization related protective functions of antibodies, as well as potential antibody-dependent enhancement of disease. But since antibodies is going to be the focus of pretty much, not all vaccine-directed conversation, but a lot of vaccine-directed conversation, I'm going to leave considerations of what antibodies are like and what they do to my colleagues who will speak about that. What I'm going to point out as my last category of comments is, what does all of this tell us about why do only some people get severe COVID-19? What are the infection immunity related mechanisms involved in the specific development of severe COVID-19? And what does our most obvious clinical epidemiological correlate of severe COVID-19, namely pre-existing comorbidities? Aging, I freely admit that I am in that category of comorbid people. So aging, type 2 diabetes, obesity, metabolic syndrome, all of these, what do they all have in common? And over the past 3 months, since May, there's been a series of papers published, Immunity, Cells, Nature Immunology, that point collectively to one fundamental convergent point. So you would imagine that this category of people who get severe COVID-19 may be predisposed by environmental factors, may be predisposed by genetic factors. We've already talked about environmental factors. I've also talked about comorbidities. People have looked for both, but primarily people have looked for genetic factors. And the genetic factors that have popped up are all uniformly, convergently genetic factors that affect type 1 interferon pathway integrity, that interrupt type 1 interferon pathways either substantially or in some very quantitatively limited fashion, or that limit NK cell activity, especially type 1 interferon driven NK cell activity in some fashion. And in study after study, it is becoming apparent that the type 1 interferon NK axis is a major pathophysiological mechanistic point at which the distinction between severe COVID-19 versus mild to moderate COVID-19 appears to be made. This is not simply genetic. Over 10% of patients with severe COVID-19 in whom it has been formally and carefully looked at, over 10 or 11% of patients of severe COVID-19 show the presence of autoantibodies against one or more type 1 interferons. So you can imagine now a whole additional layer of dysregulated immune response backgrounds on which COVID-19 severity might be driven. So really, that's my basic point at this point. I've already gone a couple of minutes over my set half an hour. Let me just point out two issues that are relevant to therapy as my last point. And those two issues are, there is a difference between the clinical utility of antibiotics in severe bacterial morbidity and the clinical utility of even effective antivirals in severe viral morbidity. Everybody is familiar with the case of herpetic outbreaks and acyclovir. Everybody is familiar with the example of influenza and Tamiflu. And everybody is familiar with the issue of remdesivir as well as of the monoclonal antibody cocktail. In all of these examples, we repeatedly point out that it is very early during the symptomatic phase that these antiviral interventions are most effective. Unlike with antibiotics, which even later in clinical morbidity show really effective clinical efficacy, that's not true of antivirals, and that's something we need to keep in mind, number one. And finally, number two, as I pointed out, the localized inflammation, immune inflammation that's innate in the beginning, amplified by CD4 T cell inflammation subsequently, that is involved in localization and in localized virus growth control, and the overflow from the location mean that when we are talking about therapeutic intervention, what we need to worry about is the differential consequences of local inflammation, which is useful and important. There are caveats to this about local tissue damaging inflammation, but I don't have enough time to get into that. But the more broad features of local inflammation, which matters for virus control, which is early during the period of clinical morbidity, where if we intervene with broad spectrum blunt hammer immunosuppressives like corticosteroids, we are liable to do at least as much harm as good, if not more harm than good. Versus later on in the clinical syndrome of severe COVID-19, when we are talking about delocalized, systematized inflammatory induction, where control of the inflammatory immune reaction body-wide is an absolutely essential feature, means that tight temporal control of immunosuppressive therapies during COVID-19 management becomes of critical immunological importance. I'm going to stop here. I've already gone a few minutes over my time, and I apologize for that. I'm happy to answer questions now, later, whatever, and I hope this has been useful. Thank you.
Sir, a very, very knowledgeable outcome from this your lecture. We have got many aspects of immunological reaction, and now I welcome our panelists to carry over the discussion. Madam Pramila, Madam, please unmute yourself, and Sanghumitra, Madam, please unmute yourself for the discussion.
Pramila Madam is there. Ma'am can start because it's my senior. Madam is there.
Yes, Madam is there.
Ma'am, would you like to initiate the discussion? So I have one question for Professor Athar. Sir, it was, I think someone has to mute. I think there is parallel. Charita, can you request? Okay, Pramila ma'am is there. Madam, would you like to initiate?
No, Sanghumitra, you start.
Madam,
You start. Okay, I will ask you. Okay, later.
Thank you, sir. First of all, this is the first time I'm listening to you, though I have met you before in ILS meetings and all that, but I have never got the opportunity to listen to you. And to be honest, till now, for us, for me, the immunological response to COVID-19 has been entirely enigmatic. People ask, for example, city value. Initially, we were very much concerned about city value. Every clinician wants to know the city value. And when the same city value in one household, someone gets perfectly well, while at the other one lands up in ventilator, then it becomes very difficult as a laboratory epidemiologist to make people explain that what actually goes wrong. And as you have rightly pointed out, being comorbid or being aged or having immunodeficiency definitely puts people on higher risk, as it has been already proven in terms of UK Biobank study and also other studies. But I would just like to, know your opinion on people, those who do not have any kind of comorbidity. People were, because that we saw particularly in the second wave, people who were apparently not having any comorbidity, not apparently very aged. I would say most of them were also below 45 years. Still they had very severe immunological responses, and many of them also succumbed. So in that case, how do we account for? Is it primarily determined by host immune system, or is it something to do with the dose of exposure and the amount of, as you told, it could be a large droplet, or it could be innumerable small droplets, or it could be the place anatomical localization. So what exactly could be the factors, or what should be our future research direction in this context? Because it's quite puzzling for all of us.
So let me direct you to a currently a non-peer-reviewed preprint that is on medRxiv. I am by and large not enthusiastic about referring people to material that is not peer-reviewed, because a lot of it is
about to be retracted also. Nowadays, I see more of medRxiv being retracted than being published.
But this one is, I think, worth making an exception for. It is from the Human Immunology study group at Stanford. And what they have done is precisely what you ask. How can we identify what the risk factors are for people with severe COVID-19 who had no comorbidities? Which is precisely the question that you are asking.
Yes.
So this came into medRxiv about 10 days ago. I happen to know that it's also being peer reviewed and it's had fairly positive peer reviews and so on and so forth. And what they've done is very careful whole exome sequencing, local immune system transcriptomic analysis as a cohort over a period of time in a fairly large cohort of such severe COVID-19 patients without any comorbidities. And what they find is that the genetic risk for such individuals to become severe COVID-19 cases is, as I pointed out, type 1 interferon mediated signaling and NK cell activation related. Not only that, they have actually developed a predictive bioinformatic model. It requires whole exome sequencing at the moment, so it's really not clinically usable. But to provide mechanistic insights, their model enables really quite sensitive prediction from the preprint of severe disease in non-elderly, non-comorbid patients, where individualized predictions are accurate independent of age and sex and are consistent across different ethnic populations and cohorts. So that's a very promising finding for me, which is why I'm making an exception and talking about the non-peer reviewed stuff. So that kind of risk stratification at the moment based on exome sequencing, but presumably one can bring the exome sequences down to a small number of genetic signatures, because it has the potential to allow at least post-exposure prophylaxis in people who are at risk at early clinical stages. And I think that this is exactly the kind of question that you meant. So
Yes.
we're beginning to get there, but we haven't quite as yet gotten there. But it's all so far. So this is a study from Stanford, and their primary cohorts are Californian. There is a study from Cambridge University where the primary cohorts are UK cohorts. There is another from the Broad Institute and with Italian collaboration. So socio-geographically diverse cohorts are all throwing up this conversion point. There are also other points that are not replicated across cohorts, but the point that is repeatedly getting thrown up across cohorts is the type 1 interferon and NK cell mediated pathway, where small quantitative reductions in efficiency. This is not about not being able to mount a type 1 interferon response or not having NK cells. This is simply slightly less functional, slightly less rapid, slightly more delayed IRF6 and IRF8 related signaling and so on and so forth. So small reductions, quantitative reductions in the type 1 interferon and NK cell pathway is appearing, to my perspective, to synergize with the ability of non-structural viral proteins to delay the type 1 interferon signaling a little bit. And it is therefore providing the tipping point where it goes from the clinical syndrome of mild COVID-19 into
severe.
The clinical syndrome of severe COVID-19.
Thank you. And I would also request any of the, ma'am wants to speak something. Otherwise, I would request any of the participants who want to ask questions now, or we can have a discussion after all the panelists. I mean, after all the
there are
box
two
are open.
questions in the chat box.
Yes, sir.
Yes, I just want to have a question that the immune response in persons with infected persons as well as these vaccinated persons, we should give protective immunity.
So this is not an easy question to answer. It's also a question that in the chat box, and it's not an easy question to answer. So let me somewhat unsatisfyingly explain why it's not an easy question to answer. As I pointed out, the live, natural, actual pathogenic virus, it's a live infection. And as a general rule, immune response magnitude and longevity is always better with live microbial infection than with non-live immunogens. So that's in favor of the infection-related immunity, as you would call it. The problem with simply saying that is, as we just discussed in response to Dr. Pati's question, as we just discussed, the live virus also has immunomodulatory and immunoevasion pathways which limit, reshape and distort immune responses, which the vaccine formulations don't have, and therefore the vaccine responses are far more uniform than natural infection responses.
And controlled also. Vaccine.
And therefore we are dealing with two sort of divergent parameters. The live infection provides.
Sucharita, can you ask someone to mute? I think there's a lot of someone. Can you ask someone to mute?
So the live infection provides a lot of advantage in our comparison to the infection versus the vaccine, but the controlled nature and the lack of immune evasion pathways in the vaccine formulation provides an advantage there. So which one is better, more long-lasting, and so on and so forth will really need to depend on ongoing cohort studies from which we will get.
Yes. I just take this opportunity to say.
Both vaccinated persons as well as persons, those who have got infection, they are also getting reinfected. Persons who had SARS-CoV-2 infection, they are getting reinfected, as well as the vaccinated persons are also getting reinfected.
So vaccinated persons, ma'am, that is breakthrough. That is not reinfected, that is breakthrough infection.
Breakthrough infection.
No. In the first place, when we say this, we are referring to a numerator without referring to the denominator. And I think that this is an absolutely crucial point to keep in mind. If you have 100 vaccine and infection naive people who are exposed to SARS-CoV-2, the general expectation, I don't think anybody has actually done this, but the general expectation, particularly from closed door examples such as the Diamond Princess cruise ship example of early last year, is that the overwhelming majority of these 100 people will get infected, productively infected. On the other hand, if you take 100 naturally infected and recovered people, or if you take 100 vaccinated people, then the proportion of people who will get infected upon exposure is dramatically, it's tenfold lower. We are not talking about a few percent reduction. We're talking about tenfold reduction. And I think that it's absolutely crucial to keep this in mind. The reason why we are noticing what Dr. Pati refers to as breakthrough infection, or in some cases true reinfection is also possible, but all of those are rare numerator events on a very large denominator background. And all of this is happening because we are in a pandemic where our values are substantially over 1. We have a lot of spread, and therefore rare events are becoming noticeable. But I don't think that we should be referring to them as the quantitatively equivalent norm. So I think that's important to keep in mind. This is also a point that I'm assuming my colleagues who will talk about the vaccine will point out when the time comes to talk about vaccine side effects and the thrombocytopenia syndrome and so on and so forth. They are extraordinarily rare events. And in fact, a lot of this very helpless statement that, yeah, we don't quite understand what's going on is happening because there are so few cases to work with.
And in this kind of population level intervention, risk versus benefit is very important. I mean, if we do not administer vaccine, what would happen? What would be the scenario? And if we do give the vaccine, what would be the scenario? It's always whenever there is any public health or population level intervention, the larger or the broader picture has to be taken into consideration rather than individual specific adverse event. I think that's what mainly the decision-making point. Yeah, thank you. I think
So there is a chat box question.
Yes, yeah, please.
About how to pinpoint the time to start the immunosuppressive treatment, that is clinical criteria. Clearly, multi-organ evidence of multi-organ dysfunction is a straightforward point. But I would also point out something else. I would point out, and again, there are predictive markers that have been brought up. The trouble is they have not been cross-cohort validated, so I think that it is early days yet to refer to them as definitive. They are all combinations of cytokine levels in blood samples. Interleukin-6 is, of course, a major matter. There are still disagreements at this point on the precise quantification. How much IL-6, how much TNF-alpha, how much IL-1 beta kind of... but increasingly what is becoming clear is that the way to distinguish between circulating cytokine levels that are primarily coming out of infection locations versus circulating cytokine levels that are coming out of systemic activation locations is going to be the crucial tipping point of full force immunosuppressive intervention. And therefore, what is going to come out eventually, and this is my guess over the next few weeks and months, is the pinpointed time to start will be a combination signature of quantitative cytokine levels. But I'm afraid at this point, I haven't seen a sufficiently well-validated signature to simply give that as an answer.
Thank you very much, sir. But it is a long way to go, whether we are able to develop this B-cell immunity, long-lasting immunity, so that we can get protected from this viral infection.
Thank you, sir. Thank you very much.
Thank you. Thank you all.
So now we shall talk about COVID-19 and pancreas. And the speaker is Dr. Rachita Nanda, who is a professor in biochemistry, AIIMS, Raipur. Although SARS-CoV-2, as we know, is a primary respiratory pathogen, as Sir has now talked about this, it has multiple focus, multiple nidus in various organs, and it has multi-organ tropism. So its effect on pancreas, whether it is a direct effect of the virus or it is an epiphenomenon, it's still debatable. Now I welcome Dr. Rachita to talk about this. Dr. Rachita, please.
Is my slide visible?
Visible.
Okay, thank you. So good evening to all the distinguished members present here and all my seniors, my teachers, my mentors, and my dear friends who are here. Thank you everyone for coming to this forum. And also to the institute, that is Bhimavai Medical College and Hospital, for allowing me to speak in this forum. I would also like to thank Dr. Satyajit Rath for such an exemplary speech, and it reminded me of our teaching days. Thank you, sir, so much. So the topic for my presentation today is SARS, COVID, and the pancreas. Now, this is a very why it is of relevance, why we have wanted to talk about the pancreas. It is mainly because diabetes mellitus is one disorder which is so much prevalent in our country. It is going to be, in our country is going to be the diabetes capital in a few years. So that is why the relevance of the pancreas more so for diabetes mellitus is there. Like I would like to say that yes, diabetes is the important one, but yes, the exocrine pancreas also gets affected, although we will not be dealing with that. But yes, the important one is the diabetes mellitus. So going down, this is the structure of the most talked about virus in SARS-CoV-2. So, it has ripped through the entire world and it is affecting millions and millions of people and claiming so many lives. So I won't go detail into it. So we know that SARS-CoV is an acute inflammation, whereas diabetes is a chronic inflammation. And we say that the relationship between these two is bidirectional. And whatever information we have got at this point about the relation of diabetes and this COVID-19 is through various cross-sectional studies, which tell us that this COVID-19 can alter the function of certain of different types of endocrine glands and the metabolic processes also associated with it, and also put patients at risk of developing maybe an acute or a late onset endocrine or metabolic dysfunction. So, and also one of the things we know that if there is a pre-existing, as Sir has mentioned, that if there is a pre-existing endocrine disorder or any inflammatory process, it can increase the predisposition for a severe infection of COVID-19. So, can you? So the outline of my talk would be on these, that we would be discussing about the risk of SARS-CoV-2 infection and its severity in diabetes, the role of associated comorbidities in diabetes with the severe course of COVID-19, the role of glycemic control and SARS-CoV infection. So where we will just try to understand the normal endocrine control of immune cells and the antiviral immune dysfunctions in diabetes mellitus, and finally the direct and indirect effects of SARS-CoV-2. Now, I would like to tell you very clearly out here that I am no immunologist by profession, but then I've tried to amalgamate a few information related to how this diabetes could affect SARS-CoV-2 infection. So first, the risk of the SARS-CoV-2 infection and its severity in diabetes. Now, this is a very common figure, and we know that this is how the SARS-CoV-2 is supposedly said to enter into the host cell, maybe through the ACE2 enzyme, where it attaches the spike protein, of course, by activation through the TMPRSS2 serine protease molecule, which helps the S1 subunit, which contains the receptor binding domain to bind to the ACE2 receptors, helping it for the entry of the virus into the, or the viral genome into the host. Now, then followed by, after it enters, it gets, the viral genome gets released, and then following this, there is a transcription, replication, virus assembly, maturation, and virus release. So these are the steps of replication, maturation, viral release. Now, the main important question, which is being asked at this point, people who have recovered from COVID-19 infection also, is that, are we developing diabetes after this infection? Many of them who were non-diabetic, who had never been diagnosed with diabetes, they are asking that, are we being, is this what we are developing after COVID? So is there a phenomenon which is developing, because of which there is a person is developing some features of diabetes? Now, we already know there are some information about how type 1 diabetes mellitus, is caused because of promoting autoimmunity, like, enterovirus against the enterovirus or the rubella. After post these infections, we develop antibodies, and, they say that it could be because of viral infections. But then there is a hygiene hypothesis which does not support type 1 diabetes incidence for virus, because they say that the less number of infection, they contribute to the more increased type 1 diabetes. So it doesn't support a disease inductive role of virus. So that is for the type 1 diabetes mellitus, which we have still some controversial information at this point. So what do we know about type 2 diabetes? We know very well that they are more prone to infection because they are already in a state of inflammatory state. They are more prone to infections, whether it is the respiratory infection or the skin infection or the genitourinary infections. They have a higher chances of developing infections. And it is known that, yes, diabetes have a reduced chemotaxis or you say phagocytic activity, because there's decreased production of the interleukins, which we always go by the syndrome which is known as the lazy leukocyte syndrome, which we've always studied all this information we know. So, taking this into consideration, that means these individuals already have certain state of state of inflammatory condition within them. So, where else can we say that these persons who are having type 2 diabetes may become more prone for the infection? Now, I would like to present some points. One is that, could it be at the site of the receptor level during the time of infection? Is the susceptibility more in these individuals? So there are certain information about few of the proteins which are associated at the entry level. One of which is a protein, which is a membrane-bound endoprotease, which is known as furin. Now, this acts as a protease molecule, and it is present at the site close to the ACE2 receptors, which is present there. So what it does is, this furin helps in the cleavage. It cleavages the S1, S2 site and allows the virus to enter into the host cells, which can then lead to COVID infections. Now, what has been seen, and few studies have documented also, that this furin is high in diabetic individuals. So that could be one of the lead to say that the entry of this virus in these individuals is more, and thus make them more susceptible for infection. The other one is the molecule that is dipeptidyl peptidase 4. Now, this also is a transmembrane glycoprotein, and it is implicated to be a component at the site of the entry of the receptor, not only for SARS-CoV, but for the other coronavirus, like even for the MERS virus. And it has been found by, studies, the few of the in silico modeling of the structure of the SARS-CoV spike protein has found that this particular protein, that is dipeptidyl peptidase 4, it interacts with the ACE2 receptor and helps in the entry of the virus into the host cell. So after that, what it does, it is said that, so this is how it is trying to enter. What it does that this will, the dipeptidyl peptidase, normally what it tries to inactivate these incretins. Now, these incretins are this glucagon-like peptide or your glucose-dependent insulinotropic polypeptide. So it tries to inhibit these incretins. Now, incretins, as we know, they try to increase the level of insulin. So when in diabetics, we see that these incretins are inhibited. Okay, so therefore the level of insulin obviously will go down and glucagon will increase. So there has been some studies where inhibitors, the dipeptidyl peptidase inhibitors have been given, and then they have seen that in that case, obviously the insulin is increased and the glucagon decreases. And in patients with COVID-19, with studies where they have seen that it is well tolerated, no hypoglycemia occurs, and it is also tolerated within a wide range of renal function. So this is another, I would say, another protein which could help at the entry level in diabetics, for facilitating the infection in case of diabetes. Now, the other one is the ACE2 protein and ADAM17, which is a disintegrin and metalloproteinase 17 molecule, which is a transmembrane protein. Now, it has been seen that high dose of glucose also, this is as I'm telling you, in animal models, this has been seen that high dose of glucose increases the ADAM17 promoter activity as well as its transcription, and its level in animal models. Now, this may be important. This ADAM17 may be important because it is facilitated by the angiotensin type 1 receptor. It may be important for fusion of the viral particles with the cytoplasmic membrane. So there is another evidence, whenever there is a high dose of, as I said, in diabetics, there is a high glucose level, there is hyperglycemia. So this hyperglycemia can potentiate or increase the ADAM17 level. And so therefore that could be another route or another point where the entry of the virus may be facilitated. These are all these information which I am telling you is at this point, nothing has been proved. All of them are being studied still. Now, so therefore, the potential mechanisms by which diabetes can increase the SARS-CoV infection could be by increased cellular binding affinity and efficient viral entry. Of course, there is other associated ones like a decreased viral clearance, a reduced T cell function, and an increased susceptibility to hyperinflammation and the cytokine storm because of an already present hyperinflammatory condition or an underlying inflammatory condition. So next, coming to the role of the associated comorbidities in diabetes with the severe course of COVID-19. Of course, diabetes doesn't come alone as such. It is always associated with some other factors. As very well pointed out, which we say that an elderly population, a male sex, I don't know why, or non-white ethnicity, and a low socio-economic status. These demographic features and certain other factors which are associated with diabetes, like hypertension, cardiovascular diseases, a chronic kidney disease, obesity, or a metabolic syndrome, and associated with these, a pro-inflammatory state and a hypercoagulable state, which can play a role in the severity of COVID-19. Now, all of these conditions, when there is an associated all of these conditions, so if this individual gets affected with that means the diabetes, patient suffer diabetes mellitus gets affected with SARS-CoV, then it causes a progression of the disease and associated hyperinflammation or treatment with steroids, we don't know, may result in an impaired, it may result in an associated hyperglycemia, insulin resistance, hyperglycemia, and which can also result in an impaired B cell insulin secretion. So all of these together can cause a severe COVID infection. So associated not only diabetes, but the associated demographic features and few other associated comorbidities along with diabetes can all result in a state of hyperinflammation, and whatever treatment given along with it may result in the progression of the disease towards a severe COVID infection. Now, as we know that, as very well pointed out by Sir, that there is a type 1 pro-inflammatory cytokine profile which is increased not only in diabetes mellitus but in COVID-19. And as he was telling, you just have to tip the balance towards the formation of a cytokine storm, and then there is a there's a breakage of this barrage, and that results in all the florid features which we see, and then resulting in the severity. So in all these conditions, these four things which we are generally speaking of, maybe interferon 1 or a TNF alpha or an interleukin 1 beta or a IL-6, they all activate certain pathways. Because as we know that although hormones act at a different site from the site of synthesis and cytokines are local hormones, they share some intracellular signaling components with those of immune response. So there is an indicating that there is some overlap in their function. So there is some overlap in their function. Now here, as we can see here, so the interferon gamma, which is released from the NK cells, they are known to inhibit the insulin receptor expression. The TNF alpha, how does it do? How does it result in decreasing the insulin sensitivity? it also tries to inhibit the tyrosine phosphorylation of the insulin receptor, which is the main which is the main step which occurs, when the insulin molecule binds to the receptor. The IL-1 beta, it inhibits or down-regulates the transcription of the IRS1 and the IL-6. It also activates the suppressor of the cytokine signaling 3 proteins, which tries to degrade the IRS1 and IRS2 through ubiquitin-mediated pathway. So all of these in some way or the other try to stop the downstream signaling pathway. These cytokines in some way stop the downstream signaling of insulin, and therefore they decrease the insulin sensitivity. Now this is occurring whenever there is an associated COVID-19 infection, because both of them the innate immunity which is affected, when a diabetic patients get infected by the COVID-19, all these pathways which were there already, they get more hampered, or they get more the pathway is more deranged, and all this results in a decreased insulin sensitivity. Next, coming to the role of glycemic control and the SARS-CoV infection, what about the normal endocrine control of the immune cells and the antiviral immune dysfunctions in diabetes mellitus? Now, when we are talking about the endocrine system or the role of the endocrine system in regulating the immune cells, I'll be talking mainly about three hormones which we are discussing here. That is leptin, adiponectin, and of course insulin is there. Now we know this leptin is secretion. It is mainly dependent on the fat content in the adipocytes. So it, whenever it is secreted, it will suppress the satiety, and it will increase the expenditure of energy. And along with insulin, it therefore tries to decrease the glycemia and also the insulin resistance. Now, patients with type 2 diabetes, they have a higher concentration of leptin, and they also have some degree of resistance also to leptin. To leptin. So what will happen is, even though these the leptin receptors, they are expressed on certain immune cells. Some of the leptin receptors are expressed on the immune cells, and they have a down-regulatory pathway, which is the JAK2 and the STAT3 pathway, which is similar to the down-regulatory pathway of inflammatory molecules like IL-6. Okay, so therefore, whenever these leptin, high concentration of leptin is there, because of the leptin, leptin resistance, it promotes the immune cell activation and proliferation. And in animals or in mice, it has been shown that it increases the granulocytes, monocytes, and the NK cells in circulation, and also the dendritic cells, which increase the IL-1, IL-6, and IL-12 and TNF alpha. So this is how the leptin is working. Now, the other local hormone which is released from the adipocytes, that is the adiponectin. Now, adiponectin is also expressed on immune cells. Now, this adiponectin, it has some functional properties with insulin, as it promotes the uptake of glucose and impairs the hepatic gluconeogenesis. Now, in immune cells, this adiponectin inhibits the activation of the NF-κB pathway. It promotes the production of the anti-inflammatory mediators and reduces immune cell responsiveness. So it acts as an anti-inflammatory molecule. So this leptin, we see that it is mainly in diabetes. It is trying to promote the type 1 response and increasing the type 1 response from the NK cells and from the dendritic cells, whereas in the adiponectin is trying to inhibit it. Now, what about the insulin? Now, insulin receptors are also shown to be found in the CD4 and the CD8 cells, and and only when they are activated, in an activated form, these insulin receptors are present, and it has been shown that it increases the uptake of glucose and also promotes the glycolytic metabolism in these cells. So whenever there is a deficiency of insulin, that is a case of say for diabetes, now the downstream regulatory molecule, that is here the CD8 or the CD8 is inactivated, and this is the CD28, which is a co-stimulatory molecule for the T cell activation. Now, they both of them, that is, I mean, the insulin receptor, because it shares a downstream signaling components with the CD28, which is a key co-stimulatory molecule, which is essential for the T cell activation, because both of them then converge on the phosphatidylinositol 3 pathway. So these receptors therefore have some functional overlap, and so whenever there is a loss of expression of these receptors on the T cells, it will impair the proliferation and the cytokine formation of the CD8 cells. So key endocrine hormones which are involved in regulation of metabolism also impact the immune cell function even in the absence of overt infection. Okay, so this is when we are having only insulin deficiency, when there is no infection at this point we are talking. So what about the antiviral immune dysfunction in diabetes? What does it do? So there are several factors which play a role in the impaired antiviral function of the cell, impaired antiviral immune cell function in the context of type 2 diabetes. But the key mediator of them we know is hyperglycemia. So we already have seen, various cross-sectional studies have shown, how glycated hemoglobin, blood glucose, all of them, they positively correlate with the duration and severity of not only this particular infection, but of any infection, any chronic infection, So, it has been seen that it impairs the recruitment of neutrophils, dendritic cells activation is reduced, there is less amount of cytokine production, the cytotoxicity and the cytokine production of CD4 and the CD8 cells and the NK cells is also impaired. So the type 2 diabetes has a profound negative effect on the innate cell function. Now, we know what it does, but do we know how it does? What is the basic metabolism underlying it? So it is again related to the metabolism and the function of the immune cells, and we say that they are tightly regulated. Now, like in the resting state, they are dependent on oxidative phosphorylation predominantly to fulfill all their energetic needs. But when it gets activated, when these cells get activated, and specifically the CD8 T cells or the pro-inflammatory M1 macrophages, they switch their metabolism from oxidative phosphorylation to the glycolytic pathway as the predominant source of energy, and also then they divert the glucose to the pentose phosphate pathway, of course, because they require NADPH and the ribose for their multiplication. Now, if proper metabolic control of the immune cells is impaired, so this has therefore will have a major impact on their functionality. For example, in that case, what would happen? If there is diabetes mellitus, which is, we say that metabolic control is not there in diabetes mellitus, then what will happen? This glycolytic metabolism is impaired. The glycolytic metabolism is impaired. It will not have adequate ATP, and there will be no effective response. So various, oxygen-dependent mechanisms do not get activated, one of which is a poor memory cell formation. Because these cells cannot get activated. So what results then? So this will result in the deregulation of the immunometabolism. So this is how this is what happens. This is a small part of the story. Now, what else can happen? So apart from glucose, the type 2 diabetes also results in a shifting of the homeostasis to many other carbon metabolites. So what are the other carbon metabolites? We know that in diabetes, the larger part of the the body then depends on free fatty acids because there is lipolysis. So it starts to use free fatty acid and generates ketone bodies as a source of nutrients. So this is what is happening. So this also similar thing happens, when we fall sick. We, we lose our appetite, we reduce our nutrient intake in that time. So what happens, the body switches to a state of fasting metabolism. And, it tries to utilize these ketone bodies, the fatty acids as a source of nutrients. However, we must remember here that at this point, the pathogens, that is the infected, the virus or the pathogens which has infected us, they keep using the glucose to fulfill their metabolic needs, the most important of which is replication. Okay, so they are carrying out their replication. Clear? Now, during diabetes mellitus, there is one more thing which is occurring also at this point is there is a lactate production. So this lactate which is being produced, it tries to inhibit the retinoic acid inducible gene protein, that is the RIG1 protein, which normally which can sense this viral infection and it can produce interferon 1, not only from, from all nucleated non-immune cells. Okay, but the lactate, what it does, it inhibits this. And because of this inhibition, the non-immune cells cannot produce the interferon 1. Okay. Further, it also reduces the ability to recruit immune cells. So this is what is happening in the this is what is happening because of an altered metabolism in diabetes. So we already know this is the proposed mechanism that, this is what is happening in diabetes, the hyperlipidemia, the advanced glycation end products, or the ROS, or the high mobility group OX protein, or all of these through various pathways, they try to increase the pro-inflammatory cytokines, which is because of which it is in a state, the diabetes we say is a state of inflammatory state. It is already in a state of inflammation. And therefore, any alteration or any just slight increase from this pro-inflammatory, from the concentration of this level of molecules, which can cause or shift that individual from an infected with controlled disease to a severe disease will not take much. So this is what we have seen, that, when there is a high amount of glucose or free fatty acids, they all, through various mechanisms which we just discussed, will try to release various types of pro-inflammatory cytokines. This is what is there in an uncontrolled diabetes. And, but when a person gets infected, the similar release of the cytokines occurs, which results in an exaggerated production of the inflammatory factors, which can lead to COVID-19 cytokine storm, and then it can cause lethal complications. And what are the direct and the indirect effects of SARS-CoV? Now, we know that, we feel that there is the findings of, there is hyperglycemia, there is ketoacidosis in patients of COVID-19. So it has prompted to question that whether there is underlying diabetes, regardless of whether it was previously recognized or not. We don't know. The COVID-19 patients are more prone for glucose dysregulation with higher number of diabetic ketoacidosis patients or patients of hyperglycemic osmolar coma. And there is more number of new onset diabetes reported in patients hospitalized with COVID-19. Now with the long COVID also symptoms, people are saying that yes, this is continuing for a longer period of time, this impaired insulin secretion or the impaired glucose disposal, and there is an increased counter regulation which is continuing for a longer period of time. So, there is this. What are the indirect and the direct effect? The indirect effect, yes, we know there is a hyperinflammation and a cytokine storm. There is a higher dose of steroids which is being given by these to these individuals. Of course, there is an associated stress hyperglycemia. Now, the direct effect or the direct effect on the pancreatic cells through the is still controversial. We still don't know whether it is replicating. Some studies, cell culture studies, have shown that infected pancreatic beta cells have impaired glucose dependent insulin secretion. But the clinical relevance is still not established. Like if I would say that if there is a loss of beta cells, then post-COVID, the patients would require insulin, which is not the case. They are not those, even with the long COVID, they are not dependent on insulin. They may have a dysregulation of the glucose metabolism. So we don't know at this point. Long continued studies are required, and still there is no information about whether there is a direct damage to the pancreatic beta cells in such a short period of time, which can damage the pancreas and prevent or destroy the beta cells. So summarizing, I think I would say that I may still be summarizing what I have introduced. That is, there is a close interdependence of metabolism and immune response. The interrelationship between diabetes and COVID-19 is complicated and bidirectional. Diabetes is an independent risk factor with factors contributing to the severity and mortality. But I wouldn't say that, summarizing the topic and saying that, yes, that's okay, we know only this much. No, where do we go from here? What do we do? What do we suggest that we should go? Where else should we move to find the answers? We need newer areas of research, research on seeing that what is the effect of this virus directly on pancreatic beta cells. We need more clinical studies. There's one area which has been worked upon and which has shown some results, research on type 1 diabetes mellitus, where it has shown that the severity in these patients is much more. We should be there on development of therapeutic interventions to target the antiviral arm of the immune system so that insulin sensitivity is improved, and also some therapeutic models to enhance immunity in diabetes mellitus, because even though diabetes is there with us for pretty long time, and how to enhance immunity and develop or improve upon, because diabetes is not going to go away and further diseases are going to come. Viral infections are, different types of viral infections are going to come. You never know what type of infections are coming. So this is, how do you help us to enhance immunity? So all these are the newer areas where we can take forth our research from whatever we have learned from this pandemic. So thank you so much for this panel and for this platform to speak, giving you just the glimpses of the Independence Day celebration, which is going to take place at our institute. Thank you so much.
Thank you, Dr. Rachita. Now I welcome the panelists to have a discussion on the topic.
Okay, thanks, Dr. Rachita, for making this, the crucial link between diabetes and outcomes of COVID-19 has remained consistent throughout. First wave, second wave, it has remained throughout consistent. I just have one, I just wanted to find out, because what we usually notice is it's not only diabetes, it's diabetes with associated obesity or overweight. They are more at risk of developing the adverse outcomes compared to diabetes. So what is your, how would you like to say that why such, it's 1 plus 1 is not 2, in fact, it's more than 2. The risk, the cumulative risk of diabetes vis-a-vis only diabetes. So, I would just like to know your thoughts on this.
Yes, as we mentioned that the severity and the progression of the disease would be more in individuals with diabetes and with the associated comorbidities. In fact, more than diabetes, obesity is a strong risk factor. More than diabetes, obesity is a strong risk factor. Even metabolic syndrome is a more strong risk factor, and it tops amongst the list, which comes above diabetes and hypertension. So yes, there is, of course, it is, as I said, the local hormones, maybe could be due to the leptin or the adiponectin imbalance ratio. Of course, there is an associated insulin resistance, which is there, even though there is a patient of, a person of obese, who is obese or who is having metabolic syndrome has not developed florid diabetes. He sure, has some degree of insulin resistance. So, there is already an underlying deregulation of his metabolism, carbohydrate metabolism or the glucose metabolism, which is associated, or affected, we may not get a florid, hyperglycemia or a diabetes patient may not even be on any oral hypoglycemic drugs or on insulin, but these are associated comorbidities and the associated, underlying inflammatory state, which may be, accentuating the disease process.
And while analyzing the effect of diabetes, was there any kind of meta-analysis, or was there any kind of segregation between those who were on insulin treatment vis-a-vis those who were on oral and hypoglycemic agents?
Yes.
Is there any difference in the outcomes?
That's still controversial, and you are getting plus minus results in lot, so few meta-analysis show that yes, it is being told that you won't stop any of these drugs, you will continue with all these drugs, but yes, with insulin it is said to be much better. Even they have said that, when you, people who take metformin, they are more protected. That information is
That's because of obesity also, because metformin is also because that's the
So there are different, information which is coming forth with different types of, the treatment modalities which is being given to an individual.
But that's, you have rightly pointed out that it's not the end. In fact, it's the beginning to understand how diabetes affects different, not only this pandemic, maybe next future acute infectious disease. And I feel COVID-19 has exposed one aspect which has been missing, the interplay between acute infectious disease and a chronic condition. COVID-19 has unveiled that. There is a need to look at both acute infectious disease vis-a-vis chronic conditions. So the interplay between the two is very important. That's what COVID-19 has taught us. So, I find it very, very concisely you have presented, and I would request if any audience have any questions, I have put in the chat box.
There is no question in the chat box.
Madam, Madam?
I just wanted to know, I think it is mostly because it remains in a pro-inflammatory state, and also it inhibits the immune cell function. That is the main cause why the diabetic patients, this SARS-CoV-2 infection is very, very, it becomes fatal. Or because the immune cell function is very much inhibited, as you rightly pointed out and given a very nice information about all these things. So immune cell function inhibition is there. That is why the direct killing of virus is getting inhibited, and this seriousness of the disease is increased. So I think in these cases, the polyclonal antibody in this treatment will be much more effective, especially for diabetic patients. What is your information?
I'm sorry, ma'am, I have no information regarding this. I'm totally clueless about the therapeutic model. I just cannot answer this question. I'll be happy if somebody takes up this question and answers.
For everybody, they are giving polyclonal antibodies. Nowadays, I think for all kinds
that has become early stage. That has become the thumb rule. If CT value low, you are diabetic. If you are diabetic, immediately they are starting that. That is no one is waiting now for evidence.
Yes.
But I don't know whether what is the outcome, and what is the response, and what has been.
No, outcomes can be known when you have a control arm. Yeah. There is no control arm here.
Yes.
Yeah.
Yes.
So
they could have got better by normal course also, but one can't take any risk.
Exactly. Thank you again.
Thank you.
May I add something?
Nice presentation.
Thanks, Rachita. Nice to see you also after a long time.
Thank you, ma'am.
Sucharita, may I add something?
Yes, definitely.
Actually, I've seen, in non-diabetic also, the SARS-CoV-2 causes pancreatitis, and that raises our amylase and lipase level also.
Yes.
So
Yeah.
that can be taken as an early marker to know the pancreatic status of this SARS-CoV-2. What I want to add.
Yes, ma'am. I didn't touch that I didn't touch acute pancreatitis. Yes, we are getting a lot of patients, with very high amylase and lipase.
Yes,
and
lipase,
the
That
features
is one of the markers.
Yeah. So they're just like, they present as acute pancreatitis. We do get, but I've not touched that portion, I have not included
I mean,
any.
it's very vast subject.
Yeah.
Otherwise, it's excellent
Due to the
presentation.
direct effect on the pancreatic cells,
Sorry?
direct effect on the pancreatic cells may be
Yes,
causing this.
yes, but then
That
still,
happens
as
in
I
every
said,
shock.
still, we still don't know whether it directly damages, how it damages, and all that thing is still clueless.
No, but whenever there is any kind of shock syndrome, the pancreatic reserve is the first one to be getting affected. That's why if you are getting insulin from external sources, your pancreatic reserve at least is there to support. That's the reason I wanted to find out insulin vis-a-vis oral hypoglycemic agent. So insulin might be doing better. I mean, no one knows, but
So
might.
in few meta-analysis, it has come out that insulin is better. Yes, it has.
It's over to you, Sucharita. You have to unmute.
Now we are going to discuss about vaccines. As we know, vaccines are the much needed agents to protect from SARS-CoV-2 apart from the natural infection. So vaccines that will induce large quantities of virus neutralizing antibodies may optimally prevent the infection, and the vaccine should have lesser side effect also. And as we know, vaccines typically require years of research and testing or trials before reaching out to the public. But to tackle this pandemic of COVID-19, the scientists have embarked on a race against time to produce safe and effective vaccine in a record time. We have so many types of vaccines available now, like our mRNA vaccine, adenovirus vector vaccine, protein subunit vaccines, and whole cell inactivated virus vaccine. So to have a broader knowledge on vaccine, I invite Dr. Ira Praharaj, scientist E, ICMR, RMRC Bhubaneswar, to enlighten us on the immunological mechanism of vaccine-induced protection against COVID-19. Madam, please, Ira, madam.
Thank you, ma'am. I hope I'm audible.
Yes, yes, madam, you are audible.
Thank you, Dr. Sucharita and the rest of the organizing members from Bolangir Medical College for giving me this opportunity. I'm going to share my screen now. Please tell me if you're able to see the slides.
Yes, your screen is visible now.
So I've slightly renamed the topic that you had given me, but I'm going to mostly deal about the many vaccine technologies which are out there and some of what we basically know as of now. I mean, some aspects of what we know about the arms of the immune responses against the SARS-CoV-2 vaccines. So in the last 18 months or so, the ongoing struggle against the pandemic.
Sorry, Ira, just 1 second. Ira, can you switch off your video because your bandwidth is showing low? So if you switch off a video, might be your voice will be more, because your voice is coming in between broken. So maybe you can switch your video.
Right. Okay. So as of now, the effective and safe vaccines are currently the most promising strategy to kind of bring some kind of semblance of level of herd immunity and control to the ongoing pandemic. Therefore, considered the most promising approach as of now for curbing the ongoing COVID-19 pandemic. As mentioned by Dr. Sucharita, we do have diverse platforms and diverse kinds of vaccines which are now available and have been licensed in different parts of the world. Many of them are still under different stages of preclinical as well as clinical trials. And what has been unparalleled here has been that the kind of speed with which these vaccines have been developed and the regulatory procedures have been carried out, and also the inclusion of many new platforms for vaccines. For example, the newly licensed mRNA vaccines, which were never used, which had never been used before this COVID-19 pandemic. Of course, the virus vector-based technology had been used for the Ebola pandemic, so it had a precedence, but still it has been used widely in this particular pandemic. Many virus vector vaccine candidates have been licensed or are currently under investigation. So what I will try to do is to cover a few things. It may not be in that particular order always. Basically the types of SARS-CoV-2 vaccines and what do we expect of a good immune response to SARS-CoV-2 vaccines. This is not really very well elucidated as of now, except some good information about neutralizing antibodies. And also I will the last few slides, I'll try to focus a bit about the threat of the emerging SARS-CoV-2 variants and what that means for the SARS-CoV-2 vaccines. And finally, just end on a note whether there should, the quest for a universal SARS-CoV-2 vaccine or a coronavirus vaccine, and whether there is a need for it. So coming to the overview of the different vaccine candidates which are out there or which have been licensed, this is the landscape of COVID-19 vaccines, which is updated by the WHO. I think this is updated every week. And so this is current as of 13th of August 2021. So as we can see, the number of vaccines under clinical development is 110, and the number of vaccines in preclinical development is 184. And if we look at the different kinds of platforms which are out there, that ranges from inactivated virus vaccines, which are more like the more traditional vaccine forms like the Generian approach that we are aware of, from that to the protein subunit vaccines, and also the other platforms which are out there are the viral vector vaccines. There are both non-replicating viral vector vaccines as well as some candidates which use the replicating viral vectors, and also of course the genetic vaccines, that is the mRNA-based vaccines. There are also some genetic vaccines which are DNA-based, and although significantly less, some live attenuated virus vaccines have also been evaluated. Now, if we come to the landscape of candidate vaccines which have already been licensed and have either received an emergency use authorization in different countries or have been pre-qualified by the WHO, we will see that the different vaccine platforms include both the RNA-based vaccines, that would be the mRNA 1273, and then the Pfizer and the BioNTech vaccines, which is again RNA-based vaccine. Apart from that, we have the viral vector vaccines. We have many candidates, including the Covishield vaccine, which is licensed in India and is being used widely. Apart from that, there are some inactivated viruses as well. This list looks at the WHO pre-qualified list, but if we look at the other vaccines which are undergoing phase 3 or have completed phase 3 and have licensed in certain countries, we can see that this again comprises of a number of inactivated virus vaccines, RNA-based vaccines, as well as protein subunit vaccines. I'll go through some of the. I'll try to go through in short some of the mechanisms in which these virus vaccines works. At least some of the for the newer ones. So we'll start with the viral vector vaccines, which, as I said, have a precedence of being used in Ebola in the Ebola outbreaks in Africa, but have not been very widely used outside of that. So in viral vector vaccines, the SARS-CoV-2 genes are introduced into non-replicating DNA viruses. There are some candidates which do use replicating DNA viruses, and then they are delivered into human cells for the production of viral proteins. And these viral proteins then act as antigens against which our immune response happens, and against which protective antibodies as well as T cell immunity might be there, and our adaptive immune system comes into play. As far as the candidates which are available, we have the AstraZeneca Oxford, the ChAdOx vaccine, or what we know commonly as the Covishield vaccines. The others which have been licensed in different parts of the world are the Russian Sputnik or the Gamaleya vaccine, the Johnson & Johnson Janssen vaccine, and the Chinese CanSino vaccine. So if we look at this is just another cartoon which is demonstrating the same. The SARS-CoV-2, mostly this targets the spike protein of the SARS-CoV-2. So the gene corresponding to the SARS-CoV-2 is introduced into a non-replicating DNA virus. So usually, let's say the Covishield vaccine, the DNA virus which has been used is a chimpanzee derived adenovirus vaccine. There are many other adenovirus vaccines which can be used, like the Gamaleya vaccine uses 2 different adenoviruses for heterologous boost. So the adenovirus 26, adenovirus 5. So these genes are incorporated into the adenoviruses, and then these can be delivered to humans for production of viral proteins. So they undergo ribosomal processing. And after that, the SARS-CoV-2 spike protein is expressed on the surface of the muscle. It can be the muscle cells, it can be the antigen-presenting cells present in that area. And these are presented to antigen-presenting cells, like it can be dendritic cells or other antigen-presenting cells. And the peptides are then presented by the antigen-presenting cells to the immune cells. So from that we have the immune response to the SARS-CoV-2 spike protein, which can be antibody mediated or it can be cell mediated immunity. So this is just a simplistic way of talking about it. So as I said, there are many different kind of adenoviral vectors which can be used. I've just highlighted some of there are many ones which are under different phases of evaluation, some which are already licensed. So we have the one by AstraZeneca, which uses the chimpanzee-derived adenovirus as the vector, and it has basically it is now in phase 4. This is a slightly older slide. Then we have the Gamaleya Research Institute of the Sputnik vaccine, which, as I said, uses 2 different vectors, one for the first dose and one for the second dose, to give a heterologous boost. And that has been said to be responsible for the good immune response that has been reported for the Sputnik vaccine. Apart from that, Johnson & Johnson and other Johnson has adenovirus 26, and the CanSino Biologics has adenovirus 5. We'll move on to the next kind of vaccine, that is the genetic vaccines or the mRNA-based vaccines, which were basically the first vaccine types to be developed, to be developed and gain emergency use authorization. But this has been possible because of years of investment into such technologies such as mRNA vaccine. There has been a lot of work going on, and these are now yielded results with the first vaccine candidates, which went into clinical trials very early. So as early as March 2020, the first mRNA-based vaccines went into clinical trials, and the emergency use authorization for the first mRNA-based vaccine for SARS-CoV-2 was as early as December 2020. So the advantages of these particular types of vaccines are these, like they can be made fit for purpose very easily. So once you have the sequence of a particular virus or a particular pathogen, and you are able to think of the epitopes, there is a chance of being able to develop these vaccines very quickly. So on the long term, this may be low cost to develop, but of course the technology is quite sophisticated. and available in very few countries. But one disadvantage of this particular types of vaccines is that they need to be stored at very low temperatures, and many countries worldwide, especially in low and middle income settings, including India, we probably do not have the cold chain infrastructure which is required for storing these vaccines before use. And that is why these vaccines have not been out in India. Although their efficacy and immunogenicity has been very good. So there are two mRNA vaccine candidates which have been approved: the Moderna vaccine and the Pfizer BioNTech vaccine. There was one more candidate, which gave very disappointing results. You might have read about it. I think it was last month, and so it was pulled off. Now, if we talk about the principle of the mRNA vaccines, these are based on the principle of the I'll go on to the next slide. Yeah, these are based on the principle of the mRNA, which contains the blueprint for the spike protein of the SARS-CoV vaccines. Okay? Now, the spike protein, as you would have seen, the spike protein is basically the target which is being used for most of the vaccines which are out there. Of course, some vaccines like the inactivated vaccine have the whole virion, but other vaccines like the viral vector vaccines and this mRNA vaccines, these basically target the spike protein of the SARS-CoV-2. If you look at the Pfizer-based vaccine or the BioNTech or the Moderna vaccine, both of them are lipid nanoparticles, and inside that we have the encapsulated mRNA, which encodes the pre-fused stabilized full-length spike protein of SARS-CoV-2. Now, this has been found to be the configuration in which it is most immunodominant, and there is a lot of immune response against it. And the mRNA is these lipid nanoparticles are used to encapsulate the mRNA, and after injection into the these are administered intramuscularly. After injection, these nanoparticles are taken up by the muscle cells and even other cells in the lymph nodes nearby, like might be dendritic cells, and inside those cells, none of this goes into the host cell nucleus. Okay, so none of this goes into the host cell nucleus. All the processing happens into the host cell cytoplasm. So ribosomal processing happens in the host cell cytoplasm, and the SARS-CoV-2 spike protein is generated, which is expressed and is transported to the cell surface of these muscle cells or other cells which are out there. These are detected by the antigen presenting cells. So the antigen presenting cells basically process them make them into peptides which can be presented to B cells and T cells, and that then again we have the immune response which is specific against the SARS-CoV-2 spike. So this part is very similar to what is happening with the viral vector vaccines also. I just have one more slide just to highlight the common pathways which are used by the viral vector as well as the mRNA vaccines. So basically, whether the mRNA the mRNA vaccine which encodes the SARS-CoV-2 spike protein, or the adenoviral vaccine which contains the which has encoding the spike protein, they gain entry into the dendritic cells. It might be at the injection site or within lymph nodes, and they lead to the production of a lot of the spike protein, as well as there is also a lot of cytokine response, which are very important. And to have that cytokine response, they basically use the adenoviral vector vaccine, especially the mRNA vaccines as well. They use specific adjuvants also, and the interferon help in the activation activation of the dendritic cells, and these dendritic cells then lead to the MHC presentation. So this presentation of the peptides is very, very important. And then these present antigen, and also there are the co-stimulatory molecules. As we know, these are important in the antigen presentation, without which it cannot go ahead. And after that, the T cells become activated. They differentiate into different kinds of T cells. So they differentiate into the effector T cells, the cytotoxic T cells, the follicular T helper T cells, and some into memory T cells. And the follicular T helper T cells then lead to the activation of B cells. which are further activated into plasma cells, right? And the plasma cells are basically the ones which produce the anti-spike antibody. The B cells can also we can also have the development of memory B cells as well. Coming to the next type of vaccine which is out there, we have, this is basically the time and tested formula, the inactivated vaccines. Many of the vaccines that we know or have been administered as children or later have been inactivated vaccines. So these inactivated vaccines contain the killed SARS-CoV virus, and this and basically this is using the killed whole virus, and the killed virus and very different components of it is recognized by the immune system to trigger a response. So there are some the advantages are that it is a time and tested formula. It is a time and tested technology. Safety for many inactivated vaccines has been assessed many times before, so may not be a big concern. But there are considerations, because for having inactivated vaccines, the virus has to be grown in large amounts and has to be inactivated properly, and it has to be ensured that it is inactivated properly. Apart from that, inactivated vaccines may only lead to the production of antibody mediated response. To have a good T cell mediated response, we need to have specific adjuvants to boost the immune response. So that is very, very important. There are many examples of inactivated vaccines being used in humans with varying efficacy and efficiencies. Influenza vaccine is one example for respiratory viruses. As far as COVID-19 vaccine is concerned, we have our very own indigenous vaccine, the Bharat Biotech Covaxin vaccine, which is an inactivated vaccine. There are other candidates, many of them from China, which are also inactivated vaccine candidates. The other type of SARS-CoV-2 vaccine candidate, which has been one of this has been licensed, has presented its phase 3 clinical results recently, the Novavax. These are the protein subunit vaccines. So these are not the whole virus, but some subunit of the virus which has been found to be immunogenic, and these are made using the recombinant DNA technology. There are many examples of protein subunit vaccines. For example, the hepatitis B vaccine that we use. So they have good previous safety records, but again, immunogenicity in the sense that a T cell response might be an issue, and that is why these also need to be administered with an adjuvant to boost the immune response. So as I said, the example is the Novavax, which has recently published good phase 3 clinical trial results. The last one which I just included, which is not licensed. No live attenuated vaccines are licensed for SARS-CoV-2, but then these have the potential that if there are some candidates which are in clinical trials, but none in phase 3 clinical trials. But live attenuated vaccines are again a time tested formula, and if we are able to have some good live attenuated vaccines, there can be many advantages, because we will have a live virus which can replicate and lead to good immune response, and it can even be administered by mucosal routes, like intranasal administration is possible. But as of now, there are no candidates which are licensed. So I just put it there because this is another technology which is under early phase of clinical trials. Now I have covered some of the immune like how the immune response happens in a simplistic manner, of course, to some of the SARS-CoV-2 vaccines. But if we have overall, if we want to talk about the types of immune response to SARS-CoV-2 vaccines, mostly the most amount of information that we have as of now, as of today, is about the antibody-mediated immune response. So we know that most of so obviously during the phase 1 and phase 2 and even phase 3 studies, the immunogenicity of the vaccines is something that is always reported on. And the parameters which are mostly reported on are the neutralizing antibodies. These neutralizing antibodies basically have been shown to have a good correlation. The presence of neutralizing antibodies has been shown to have a good correlation with decreased viral load in the body and with being protected against the virus to some extent. But then most of the vaccines that we have discussed lead to the production of neutralizing antibodies against the spike protein, and we do not really have much information about the response, some of the ones like the whole inactivated vaccine has given some data on the nucleocapsid antibodies. The other very important aspect which has received less of eyeballs, I would say, but is equally important is the cell-mediated immune response. There is also probably a role of the innate immune response, as was contemplated and still be contemplated with the role of the BCG vaccine in COVID-19. And finally, also there is very less known about the mucosal immune responses and the IgA levels and the antibody levels at the mucosal sites, which may provide infection, which are very important when we talk about protection against infection rather than just disease. Now, in order to understand the vaccine-induced immune responses, the best approach would be to, when we have immunogenicity data or immunologic data, and when we correlate them within the context of vaccine efficacy studies, what it does is it gives us a very good opportunity to come up with good correlates of protection, because in vaccine efficacy studies, the outcome is the disease or severe disease. But the fact remains that the phase 3 trials, although many of them have published immunological data, the amount of data is available in such trials, phase 3 trials, is still limited. And that is why what we know as of now it is based a lot on the immunologic responses to the vaccine on the phase 1 and phase 2 clinical trials, where we do not really have a clinical outcome as the endpoint. So that is why it is important to really use all the samples, which are valuable samples, which are available from phase 3 trials, and to have parameters measured, so that we can come up with some good correlates of protection, which can be used as a surrogate for, let's say, following somebody up for a long time to see whether somebody develops disease or not. Now, I have just a few slides where I am trying to, so that is the reason why I have just included some of the studies which have looked at the antibody responses and the T cell responses, as well as there is efficacy data against for these particular vaccine candidate. So I'll start with the mRNA vaccines for both the Pfizer as well as the Moderna vaccines, which of course, as we know, these have been found to be highly efficacious, and even the ongoing effectiveness of the post-implementation studies, these have been found quite high efficacy, effectiveness. So what has been found is the S1 binding antibody is found even after the first dose in mRNA vaccines. And of course, the responses are increased following the second dose. What is significant to see is neutralizing antibodies have been found for these mRNA vaccines only after the second dose. But we know that even after first dose, the efficacy of the vaccine is quite is considerable. So it is important to now consider that it is not just the neutralizing antibodies, but other antibodies as well, polyfunctional antibodies, which might be at play here. So it is not enough for us to just focus on neutralizing antibodies, and it is also important to consider the other types of antibodies and other polyfunctional antibodies which are out there. As far as T cell responses are considered, after the second has been found to be a TH1 polarization and increases in antigen specific interferon gamma CD4 and CD8 T cells. So this is similar for both the Moderna vaccine as well as the Pfizer vaccine. Now coming to the viral vector vaccines, I've just listed out some of the ones which are already licensed. Now compared to the mRNA vaccines, the efficacy against symptomatic infection and disease for the viral vector vaccines as reported for the ChAdOx has been lesser, but still considerable. As far as the antibody responses corresponding to that is concerned, the S-binding antibody have been found to be present 14 days after the first dose, and of course by 28 days it is increased. Some studies have also noted peak IgM and IgA responses at day 14 or 28. As far as the T cell responses are concerned, these have also been elucidated for the viral vector vaccines with peak T cell response 14 days after the first dose. This slide is about the inactivated vaccine. So I'll just focus on the indigenous inactivated virus vaccine, that is the Covaxin of the BBV152, the Bharat Biotech vaccine. Now this is, as I said, being an inactivated vaccine, it has to use an adjuvant so that there is some T cell response also. There is some T cell response and its immunogenicity increases. So for this particular vaccine, they have used aluminum hydroxide. Of course, is a known adjuvant, but apart from that, some TLR agonists, TLR7 and 8 agonists have been used. The efficacy studies as declared by the company after 2 doses has been approximately 78%, and some of the immunogenicity data that they have published has shown considerable anti-S binding antibodies which have increased considerably after the second dose, and also some of the published data shows a strong bias towards the Th1 cell phenotype, which is probably because of the particular adjuvant which has been used. Now, many times we try to compare immune responses of SARS-CoV-2 vaccines from like when we read about the like neutralizing antibody titers from one article to another. Now, although most of the licensed and phase 3 vaccines have reported some antigen-specific and neutralizing antibody T cell responses, many of them have used variable antigens. The specific antigens that they've used are different from study to study. So it may not be very prudent, I would say, to compare them directly. But what has been has happened is comparison can be done based on analysis with the convalescent samples, because for many of these trials and studies, they have compared the antibody or T cell responses after vaccination compared to natural infection of patients who have convalescent patients. So this is just a slide from a review which I thought would be useful, which shows the comparison of antibody responses induced by different COVID-19 vaccines. As I said, it's not a direct comparison. What they have done is they have calculated what they have done is, Dr. Manthi, there is some thank you. Yeah. So what they have calculated an index where they have the index between the antibody, the neutralizing antibody after vaccination compared to the neutralizing antibody in the convalescent seen in the convalescent plasma. So as we can see, the mRNA vaccines, of course, have very early and good antibody responses, but other vaccines which are also licensed also pretty much reach at least 1, which is where, I mean, at least we can say this matches the antibody response in the convalescent plasma after the second dose. So here we do have both the mRNA vaccines, we do have the viral vector vaccine, the Gamaleya as well as the ChAdOx. The ChAdOx is this, and the Gamaleya vaccine is the red one. And we also have one inactivated vaccine, the BBV152 is basically the Covaxin. So with this, I will just focus on the next 2 slides. I will just focus on immune responses in in 2 different age groups, and some of the data that is available out there. Now we know that immunosenescence is a big issue when it comes to vaccination for the elderly, and it is so for it is important to see whether it is so for SARS-CoV-2 as well. Now, immune senescence generally leads to a number of parameters going down, including cytokine and chemokine production in old age, the decreased reactive oxygen species production, and decreased proliferation of the different types of T cells, as well as T cell diversity. So both the adaptive as well as the innate immunity is affected. Now, there are some published studies, but again, these published studies are with the mRNA vaccines, where they have shown that immune response to SARS-CoV-2 in the elderly is significantly lower in individuals who are more than 80 years old. So most of these, these are data from. This particular data is, I think, from Sweden. So the production, not only the serum neutralization and levels of binding IgG, but also the production of interferon gamma and interleukin 2 has been found to be lower in older participants. So in this particular study, which I put the figure here, they had also they did also evaluation for the different SARS-CoV-2 variants. I think there will be a talk regarding the SARS-CoV-2 variants after this. So what they have found is for the immune response is quite dramatically decreased in the older population compared to the younger healthcare workers which were included in this study. Recently, I think just 4 to 5 few days back, there has been a published study which has looked at the immune response to SARS-CoV-2 vaccines in adolescents. Now, as we know, in our country, the vaccine is not yet licensed for adolescents, but in some Western countries, based on this kind of data, they have started giving vaccines to adolescents. Now, this is again for the mRNA vaccines, which have been found to have an acceptable safety profile. As far as the immune response was concerned, when they assessed the neutralizing antibodies, and the comparison group was young adults, which is 16 to 25 years. And so they compared the adolescents in 12 to 15 years. For the mRNA, for the Moderna vaccine, they found similar neutralizing antibody titers. For the BioNTech Pfizer vaccine, basically the age group 12 to 15 years had a much higher immune response than young adults. As you can see, the geometric mean ratio is much higher when it is calculated compared to the young adult age group. I'll have a couple of slides. I have a couple of slides on what the emergence of the SARS-CoV-2 variants means with regards to the SARS-CoV-2 vaccines. Now, the SARS-CoV-2 coronavirus and the RNA virus, we know that it will evolve and it will mutate. So, but what has been concerning in recent times has been the emergence of variants of concern, which some of which have been shown to have increased transmissibility and have been leading to the increasing cases in many countries, including for the second wave in India, as well as the third wave in many Western countries as well. Now, as we know, as of now, the WHO has identified. The WHO basically updates every week and identifies variants of concern. They have the new nomenclature being the alpha, beta, gamma, and delta. And the variants of concern, one of the important things based on which it is decided whether something is a variant of concern. One is transmissibility. Second is whether the mutations which are there for this particular strain or the mutant, whether it is capable of immune escape. So that is one of the major concerns. I won't go into the details of the variants of concern, of course, because there is going to be a detailed presentation on that. But this is the latest epidemiological report from WHO, where it shows the widespread of the different variants of concern, especially the Delta variant, which has now been reported in more than 140 countries throughout the world. The Delta variant is the B.1.617.2. And it has been basically blamed for the for the second wave, as well as for many of the countries which are now looking at the specter of the third wave and increased transmission. Now, this is one useful slide which I thought I should project. So this is again from the WHO epidemiological report, where they have just basically summarized the vaccine performance with respect to the different variants for the different vaccines. So I'd just like to, they're only focused on the variants of concern here, the alpha, beta, gamma, and delta. So with regards to neutralization, which is basically can be taken as a surrogate of, it can be indicative of some degree of immune escape, I would say. There is a marked decrease for many of the vaccines with regards to the beta variant. Now, the beta variant, or which was otherwise also known as the South African variant, or the B.1.351, has been found to have, in vitro studies by neutralization, they have shown that neutralization against this particular variant is greatly decreased. As far as the Delta variant is concerned, it is not as bad as the beta variant with regards to the decrease in the neutralizing antibodies action or titers, but it is still considerable, and that is also a cause of concern. And especially for the Chadox vaccine of the AstraZeneca vaccine, this decrease in the neutralizing titers has been seen. Now, with regards to viral variants and with regards to vaccines, there are of course many different priorities. But I just want to highlight a few which have to do with what we need to think about with respect to the different viral vaccine candidates per se, and how we may need to modify vaccines in the future. So for coordinating the worldwide response, we may need, the characterization of viral variants of concern is of course very, very important, and that is why there is so much emphasis being given on the genomic epidemiology of SARS-CoV-2 and the emerging variants of types. It is also important to look at the antigens. It's not just most of the vaccines that we have discussed have been focused on the spike protein, but it is important to look for other targets which might be more generalizable and which might lead to an immune response which is not affected when the spike protein mutates and we get new variants. And also deciding with the variant data needs to be used for modification of existing vaccines. So as of now, with the amount of neutralization antibody titers which have gone down, there is some cause for concern, but still, most of the studies have shown that the neutralization titers which are out there are still enough to protect people. So we won't really say there is immune escape from vaccines as of now, but it is a specter that we are staring at. So the variant data should be used very judiciously to see if and also in the future there should be the regulatory assessments and the time taken to have these regulatory assessments has to be really to speed up, because if these such variants emerge which lead to immune escape completely, then we may need to come up with new vaccines very, very quickly, and for that regulatory assessments also have to move ahead quickly. These are just my last few slides, so where I'm just going to highlight a few things that for future considerations for COVID-19 vaccines and for vaccine development. One thing that is very, very important is to identify what is a good immune response. When do we say that if a person has this particular immune parameter, it may be antibody titer, it may be a particular type of subgroup of T cells or anything. Is there any correlate which can be correlated very well with the clinical outcome? So the WHO has identified that there is an urgent need to accelerate to establish the good correlates of protection, both against infection and disease, and which will work also for the variants of concern. And this is very important for two things, because in the future, it is not ethical for us to have placebo-controlled trials for SARS-CoV-2 vaccines probably. So it will be difficult to have any phase 3 efficacy trials to carry out placebo control. So if we have a surrogate of protection or a correlate of protection, and we can measure that instead of recruiting patients, instead of recruiting individuals and having to follow them up over time, we can quickly come up with good vaccine candidates, and the vaccine scenario can move ahead. Also, in the long term, as more and more people get vaccinated, hopefully, there is hopefully going to be decreased number of cases and decreased incidence, at least in many areas of the world. And there it will be difficult to carry out phase 3 efficacy trials. So having correlates of protection, which correlate very well with the clinical outcomes of decreased disease or even decreased infection, are very, very important. It is the second thing that I would like to highlight is to have a long-term follow-up of individuals who are vaccinated, because to know exactly how memory or B cells respond to the risk of infection or severe disease following vaccination. With regards to what next generation SARS-CoV-2 vaccines will entail, what do we need to be cognizant of? Of course, this is already out there. The vaccine developers are focusing on these aspects. So there are, of course, firstly, the considerations regarding the emergent SARS-CoV-2 vaccines. Secondly, including antigens other than the spike protein, which might be genetically more stable, which probably which are not susceptible to the SARS-CoV-2 variants. So most of the mutations that we see in the variants are in the spike protein. So including SARS-CoV-2 antigens other than spike proteins, but they should also be immunodominant. So that is an important thing to see. So we need to understand better the role of both anti-S and let's say anti-nucleocapsid antibodies, whether what provides infect protection, what is a surrogate of protection. Also, finally, in the future, when the developing vaccines will only protect not only against severe disease, but also against transmission, or so-called sterilizing vaccines. In the last couple of couple of months after the advent of the emergent SARS-CoV-2 variants, there has been an increasing the importance of universal SARS-CoV-2 vaccine or a coronavirus vaccine has been highlighted. And there are two scenarios which make this extremely useful. The first and foremost, which we are staring at, is if the COVID-19 vaccine mutates to invade existing vaccines, which is a possibility, given that there is still a large proportion of the world which is still unvaccinated. And the second is if we have another epidemic or pandemic from a different coronavirus in the future. And so I think that it is not a question of when, but it's not a question of if, but when we have the next epidemic or pandemic from a coronavirus. Each of the decades of the 20th century, we have seen one emergent coronavirus, which has been a public health menace, and we need to be prepared for the future. So I'd like to end my talk with this particular thought on the universal SARS-CoV-2 vaccines, and there are ongoing efforts on finding common targets across coronaviruses that trigger immune responses to all coronaviruses. Hopefully, we will have an opportunity to discuss it again sometime. Thank you very much for your patience.
Thank you so much, madam. Now it's over to the panelist for a discussion.
Madam Koibe Kiju.
Thank you very much, Ira, for such a nice presentation, elaborate presentation. It is that we need to have protection, immunity against SARS-CoV-2, so that we don't get infection. The transmission risk is also reduced, and the disease outcome is also very important, so that we can think that the vaccine is effectively used for protecting against all these things. And the adaptive immune response also should deliver long-term protection. What is your till now, I think there is no vaccine which can assure all these things. No. So you're still in the developmental way.
Yeah, ma'am, with regards to long-term protection, there are some of the vaccine candidates do induce T-cell response, so which and memory T as well as B-cell response, which should be indicative of long-term protection. But of course, there has to be follow-up to see that how much it translates to clinically and in the long. So, yeah.
Okay, thanks, Ira. And I think there are a few questions for you. Like, how is the interval between doses calculated? I mean, like, for example, Covaxin, we have 4 weeks. At the same time, Covishield, we have 12 weeks. So on what basis?
So the interval between so especially for the Covishield vaccine, some of the interval findings that they found was a serendipitous finding that for a subset of the individuals, they saw that when they received the vaccines later, the immune response was better. So that is there, but for most of these doses have been calculated during, in the early in the phase 1 as well as phase 2 studies, where they looked at what is the immunogenicity when we give if they have looked at different doses of vaccines as well as different time periods at which the second dose was given. So that is not something specific for SARS-CoV-2. That is how it is done for most of the vaccines in the development stages.
So calibration of dose and calibration of scheduling has been done based on phase 1 and phase 2, and wherein they do multiple in time interval and multiple doses and to find out the optimal response.
Yes, ma'am.
And the second is, what is the current status of the usefulness of a booster dose, particularly for healthcare provider? Do we need a booster dose?
Well, with regards to that, ma'am, we don't really have enough data. We don't have data from India, but I mean, else in the Western world, for some of the mRNA vaccines, because the mRNA vaccines, it is known that the booster dose does help. So they are proposing a booster, the third dose. But as of now, for the vaccines which are currently available in India, we do not have enough evidence to say whether or not it will be able. For inactivated vaccines in general, booster doses are useful.
I mean, for general. I mean, generally for yes. And third is already, I mean, what is the lifespan of this antibody as the titer is decreased drastically in yeah, that is, I also wanted to find out, because many individuals are witnessing decline or attrition of antibody. So how?
There are two things to the antibody levels. Some of the studies which have, these are not necessarily done with the vaccine candidates which we have in India, but as long as there have been studies from Australia which have shown the presence of these antibodies as long as 7 months after being vaccinated, after vaccination, and even more. But then the thing is, it is not for any vaccine which is out there. We do not really only need to think about the antibody lifespan, because even when we talk about, let's say, hepatitis B vaccine, the antibody titers do not stay at the same level. They do come down. Many times we do become negative also. But then what is important is if there has been an immune response and the T cell and the T cell immunity has kicked in, and there is some amount of immune response, then again in the future, if when we are facing the same pathogen, let's say SARS-CoV-2, then our immune system should kick in, and our antibody levels should rise again. So raised antibody levels in general is not something that is very, beyond a certain period, the antibody levels being raised is neither expected nor is it good. For most vaccines, we do not know enough for the SARS-CoV-2, but just the fact that antibody titers are coming down should not be a big reason for concern unless we have more evidence, in my opinion.
Okay, and the last is more of a statement rather. Universal coronavirus quest will be like remdesivir. SARS and MERS vaccines had failed earlier. So what's your
Well, ma'am, so I mean, with regards to the quest for SARS and MERS vaccine, I'd just to like to elaborate is somewhere probably because the number that they did not really fan out into pandemics, I would say. The impetus to go for a universal vaccine against coronaviruses was probably dampened to a certain extent. There has been a lot of work on even trying to have a universal vaccine against influenza viruses. And also now there are a number of universal coronavirus vaccines which are under not yet in advanced clinical trials, but in preclinical trials, etc. So we can be hopeful, but just because the SARS and MERS vaccines had failed, I wouldn't say that it is not possible.
Yes, okay. I mean, there should be a note of optimism with whatever we are doing. Yeah. Thank you, Ira.
Can you take more than one type of vaccine?
Sorry, ma'am?
Can you take more than one type of vaccine?
Different platform vaccine.
Different platform.
Okay. Ma'am, there has been just last week there has been instances when like let's say viral vector vaccine has been taken, and after that an inactivated vaccine has been taken, and that has led to good immune response. So that is something which was happened the findings were published for a small subset of individuals only, I think last week. And similarly, I think in some studies in the West, they have shown that after a viral vector vaccine, if you take an mRNA vaccine, the immune response is very, very good. So I think, but it needs to be, but it needs to be evaluated on a large number of individuals, I would say, ma'am.
Because after the antibody level is getting decreased, you can have another type of vaccine, is it not? Because it is not permanent.
There is some evidence, but it again depends on the type of vaccine. Like as I said, there is one study from I think that is one European country which is there, where they have shown that viral vector vaccine followed by mRNA vaccine, there is a huge boost in the antibody level. So I don't think we can generalize it, but it has to be evaluated for different vaccine combinations.
If I'm not wrong, I think CMC Vellore got an approval to study this mixing of vaccines 2 days back by the DCGI.
They are doing it on a larger number of
300 people on volunteers. They'll be doing. Okay, over to you, Sucharita.
Thank you, Ira madam, for such an elaborate presentation. A lot of queries have arisen whether we should take a combination of vaccine or should we take a booster dose or like that. The vaccination drive began in India in the March. So till now, till 13th August, as I have seen, about 52.9095 crores of vaccines have been administered under the nationwide vaccination program. And now the active cases have also declined. Even then, it has been observed that some people have suffered from COVID-19 even after completing their vaccination in full dose, and they have developed severe to moderate disease and even succumbed to the COVID-19. So now a lot of queries arise in our mind about how long and how much protection these vaccines provide to us, provide to the vaccinated individuals against the different variants of SARS-CoV-2. And now that we have Covaxin, Covishield, vaccine from Johnson & Johnson, Sputnik V, all these are available in India. So does it make a sense to receive a combination of vaccine? Or shall we go for a booster dose? And as we know, ICMR has already recommended that one can go for mixing of Covaxin and Covishield vaccines, which is declared to be safe and also give a better immune protection against COVID-19. So to talk on this, we have none other than Padma Shri Dr. R.R. Gangakhetkar sir. I welcome you, sir. He will be speaking on development of immunity post-vaccination, whether we need or not, if we can take a combination of vaccine. He is now holding the prestigious CG, Dr. CG Pandit, National Chair, ICMR. I welcome you, sir, to deliver your talk.
Let me first thank you, Madam, for inviting me to talk on this particular issue, which is a major dilemma because we really do not know much about duration of protection from 2 dosages or even the need of third heterologous dose. But we need to take call, especially as the evidences are emerging. Just to give a background, because when you take such decisions, you need to recognize or remember what all we have faced as well. No, none of us ever were aware of the asymmetric warfare that was to begin in 2020 in the month of January. We know that this disease tends to spread through droplet infections. It's largely asymptomatic, but it kills weak and the old people. We also know that though we know that it kills many, but at the same time, we also do not know what would be the long-term impact of post-COVID syndrome, given the fact that it tends to affect different organs dramatically in the post-COVID syndrome. As Ira did try to talk about these vaccine platforms, the need for looking at development of vaccine was recognized by most of the scientists, and the platforms for these vaccines were already ready for HIV and Ebola. They were sustained, and people started working even on newer platforms in addition to the old recognized platforms per se. What was most important for us to recognize that the vaccine trials, which were not expected to give such a fabulous response in terms of efficacy, we find that the responses, the initial figures of protective efficacy were very high, almost close to 100%. And that led to a lot of optimism in our mind. And majority of these vaccines were coming close to more than 80 to 95% protective efficacy. What is also important for us to recognize that at that juncture, we felt all these vaccines are likely to give you 100% protection from death, especially because the severe COVID disease would be prevented by these vaccines. It had an additional feature, the newer evidences that were generated at that time, they also indicated that if you provide vaccine to a healthcare worker, even the risk of secondary transmission within the household after 2 months of vaccination was reduced by 50%. So essentially, it meant that the individual benefited, and also the people with whom he tends to mix a lot were also benefited largely due to the vaccine. And the countries went into rapid rollout of the vaccines and tried to look at how would be its impact on the second wave. And what was it that was essentially seen? That in many countries where vaccination drive on prioritized population was initiated, they found that the number of hospitalizations dropped, and perhaps it had a major impact on the pandemic in their own areas per se. What was also important is when the priority groups were formed by age groups, because the risk of death or risk of development of severe COVID disease is very high among those who are older and also those who have chronic morbidity. The categorization was done in order to provide vaccines in a prioritized way. The older you are, they were categorized first to receive the vaccine, especially in UK. We started in a strong way there. And what was it that was seen? That there was a dramatic effect in hospitalizations that were occurring within next 2 months period, and they could stop the wave from increasing in their own areas, and also ensuring that the adverse outcomes of death or severe COVID disease do not come up. And this is classically shown in this graph, where you recognize that the older you are, the more you tend to appear to be protected if your vaccination or if that population is saturated with vaccines in that age group per se. Everybody thought then that now we can reach the herd immunity, which was one of the concepts that was prevalent at that juncture. Because people felt natural infection can induce protection, and in addition, there would be vaccine-induced protection so that you can reach very quickly. So there is a biological tool, and also the infection would favor reaching that little earlier. Now, one of the questions that comes to one's own mind, how long does this immune protection last from the natural infection? Because that was one of the things which was an important component of reaching to the strategy of reaching to the herd immunity. What is it that perhaps people came to know? In one of the studies, they classically showed that this protection may last up to a period of 8 months, and after 8 months, the antibodies may start waning off, whether it is spike protein related antibodies or even nucleocapsid antibodies. But then people thought that it would perhaps be that people will have a protection that might come from T cell immunization, but T cell sensitization. But one of the issues that came up was that we didn't have so much of data. So people were wondering, how do I capture that particular data? Some studies that have been done on bone marrow, they tended to suggest that memory response was also detectable among those who were naturally infected even after 1 year's time. And then the entire findings that were coming from the laboratory side, they were also supported very strongly that natural infection also protects you, because we could also find a surrogate that the rate of reinfection that tends to occur is very, very low. That is only about 0.4%, which essentially supported the findings that were being seen in the laboratory. So people thought that natural infection-induced immunity would continue to be extremely protective. And then slowly they started moving towards the so-called herd immunity concept little strongly through vaccination. But none of us thought that the virus would mutate so often. It does not have the transmission dynamics of that kind, because once the virus enters, on an average, the survival of this virus is only for 15 days period. And if you look at selection pressure that could be put on this virus, you find there are no specific antiviral drugs. If at all, if something can come, it could only be through immune pressure, because the effective antiviral drugs are not there at this juncture. The only issue that was also a botheration for all, that the virus may survive little longer among those who are immunocompromised and those who are older, and perhaps provide an opportunity for this virus to mutate. Today, if you actually reflect back, you have more than about 10 major variants that have been reported so far. Unfortunately for us, among the 4 variants of concern that have been classified, Delta variant has been reported first from India. People tend to think that it has actually developed in India, where from what? No, we don't have sufficient evidence. But Delta variant is one of those variants that is causing havoc as of now. Now, one of the things which we have to understand, when these variants are evolving, because this is a natural phenomena, these are RNA viruses, they are going to mutate ever. Now, one of the best things that we have to remember about UK is it was one of those countries which invested heavily into genomic surveillance. But what does this genomic data tend to tell us? That it tends to tell us that every time a new variant which was more fitter, which was more transmission efficient, it tended to prevail and it replaced the older variant. And today, if you actually see, even in UK, the proportion of people who may be having Delta variant among those who are newly infected continues to go high. You look at majority of the countries where the infection currently is even raging strongly, whether it is United Kingdom, whether it is India, whether it was Germany, United States, everywhere, the proportion is reaching almost close to 90 to 100% in those areas, which means the variant is replacing the virus that was present there earlier. What is the impact of these mutations? Now, one of the impact is the mutations can result into increasing the transmission efficiency. It can also impact the protection that occurs from natural infections or also from the vaccines through escape generation of escape mutants. Now, if you look at the data that is emerging for Pfizer and Moderna, because essentially mRNA vaccines are considered to be ones which have better efficacy figures compared to rest of the vaccines that are coming up. What does this slide show? Now, it tends to show you that if you compare alpha and delta variant for the 2-dose effectiveness of these mRNA vaccines, you suddenly start finding that delta variant tends to ensure that there would be lower efficacy of these vaccines against delta itself. And that's something which is crucial to understand. Therefore, the fear started coming up. Now, if you look at the effectiveness of different vaccines, because essentially first what we looked at were mRNA vaccines, but then we don't have so much of these mRNA vaccines which are available. So essentially, what would we look like? Would like to look at? We would perhaps look at the Covishield kind of a preparation, the one which we know as AstraZeneca vaccine. Even for AstraZeneca vaccine, the efficacy against that Delta variant became lower, and that's something which is essential for us to understand whether it was 1 dose or whether it was 2 dose. Delta variant reduced the efficacy of this AstraZeneca vaccine at that juncture. Now, how did we take this particular study? Now, one of the things which we captured was, people thought that would these efficacy figures be better if you use 2 dosages of vaccine, as the earlier slide showed, that if you use 2 dosages, the efficacy increases, but compared to 2 different variants, it would still be lower. So when people looked at this particular approach, they thought giving 2 vaccines could be a better solution, even if there is Delta variant or any other variant that is prevalent. But then when people started estimating the efficacy against prevention of disease or prevention of infection by variants and different vaccines, it was realized that mRNA vaccines continue to dominate as far more effective vaccines, and rest of the vaccines drop their efficacy significantly, especially against infection, if not so for the diseases itself. Now, Covaxin was found to be useful in India. NIV worked over that issue in the lab. No, but the Covaxin as well as Covishield were found to be working really well in our own setups in lab. But then only lab is not going to dictate whether those findings are likely to be truer in the population itself. So if you look at the data that tended to come for the vaccine efficacy against infection and hospitalization, you will suddenly find that even Moderna and Pfizer started losing the efficacy dramatically in presence of Delta variant. For Moderna, the efficacy figure came down to 76%, but for Pfizer, it came down dramatically low to 42%, which essentially led to a lot of thinking in terms of third dose or strategies to ensure that vaccine response could be boosted. When it comes to breakthrough infections from Delta variants, one thing which we had noted was, one of the studies tended to show you, at least 2 studies, that Delta variant is associated with lower incubation period, higher viral load, prolonged PCR positivity, and it is associated with lower level of vaccine-induced neutralizing antibodies, which became a cause of concern because people were worried that if the vaccine response is not good, perhaps Delta variant can still breach the protection and cause infection to individuals. Now, when it came to these issues, one of the issues that also became very important was how is that severity of COVID disease affected by vaccination status? If you actually compare those who are not vaccinated versus those who had 1 dose and 2 dosages, we find that the severity tends to come down, but it doesn't disappear altogether. And that's a cause of concern, because even people could have severe COVID disease even if they had 2 vaccine dosages per se. And one needs to probe into why such a issue tends to arise. Now, one thing which we have to realize, one of the studies tended to show different mutations that occur and what was the impact on PRNTs per se. But if you actually look at the drop that actually was seen, may not have had been reflected so strongly, and that mentality continued for a long period of time, that everything that you see in lab may not be seen across. And this was reinforced further if we reflect again. Now, if you look at the recent phenomena, you find that the 7-day rolling averages of new cases in better immunized countries have sharply risen up. Whether you consider UK or European bloc countries, no, you suddenly find that the numbers are rising, and that became a concern per se. But you look at new hospital admissions that were occurring in better immunized countries, you find that the rise was not as dramatic in those areas where the countries were better immunized per se compared to rest of the countries. If you try and see that what was the proportion of patients who were landing up into number of patients who were landing up into ICU in better immunized countries, you find that excepting US, which has its own issues, which most of us are aware, rest of the European bloc, they found that the vaccine protection was strong enough, and though it increased the number of cases that were occurring every day, but its translation into adverse outcome was affected, was controlled dramatically by these vaccines, and the proportion of people who were getting hospitalized or even going into ICUs was dramatically low because of vaccines. Now, when you actually look at it, few days back, one of the papers that came was efficacy of this Pfizer vaccine at 6 months. Now, so far, all of us know that the data was limited to the first week itself, when the emergency use authorization was provided. And what is it that this data and this graph tends to tell you? That vaccine efficacy drops off as the time passes by. Now, if it was 96% in people who had received vaccine between 7 days after receiving last dose of vaccine, between 7 days and 2 months, it came to 96%. Between 2 to 4 months, it came down to 90%. And between 4 to 6 months, it came down to 84%. Though there may not be a significant statistical significance that you see, but this is intuitively likely to be seen accurately. And therefore, because this is dependent on the numbers that you are using and the severity of the outbreak in that area. In any case, these are first generation vaccines which don't protect you against infections because they don't confer sterilizing immunity to you. So they are inefficient in protecting against infection. But what is essentially going to happen because of that? There would be an increase in incidence of asymptomatic and mild COVID infections, but the virus will keep on hunting because the virus would continue to remain in the population. It will hunt for those who are vulnerable or those who are unvaccinated and try to produce the adverse impact on the health, which we are worried about. Now, if you look at immune response, and if you think that the third booster dose, can it be given, especially for AstraZeneca vaccine, because this remains something which is relevant for our own country, you find that each dose that you are providing, there is a boost that tends to occur, and there is a drop that occurs when you give dose for the first time, then second time, and third time. If you look at the graph, you will suddenly realize at the third dose, after the third dose, it is the third dose is higher than the second dose, and also higher than the second dose is higher than the first dose. That is also reflected in the PRNT values. The neutralization that occurs against the variants, it tends to improve if you are giving third dose to those individuals. Now, one of the issues that becomes an important question to address, would it also impact the T cell sensitization that we tend to talk about? If you look at interferon gamma ELISpot assays that were done after second and third dose of AstraZeneca vaccine, it was found that third dose, even if it was given all 263 to 266 days after the second dose, it tended to confer better protection even from the memory cells point of view. And therefore, this is something which may be a desirable thing to provide third dose. Now, should we be providing third dose to all the persons? We don't have such evidence. Most of us, if they are likely to get asymptomatic or mild infections per se, we need to prioritize perhaps a few groups to reduce adverse health outcomes among them. Now, which are those these groups for which we have some evidence at this juncture? If you look at the kidney transplant patients, when they provided these particular vaccines, mRNA vaccines, especially Moderna, was provided to kidney transplant patients, there were some who were responders, there were some who were non-responders. But what was it that was seen? If you provide the dose to the third dose to a responder as well as non-responder, there is a dramatic rise in anti-RBD antibody titers, and therefore it was perceived that we perhaps need to think about these transplant patients per se. And this was proven little more and little better by a randomized control trial that was done for Moderna vaccine's third dose, where they found that it increased, not only it increased the anti-RBD titers, antibody titers dramatically, but it also ensured that there is sensitization of the T cells that tends to occur there. Now, one of the paradox, one of the, let's say, instead of paradox, let's say one of the limitations in this vaccine development has been the inclusion of older participants and those with chronic morbidity in the vaccine trials that were done in the first round itself. And why am I saying that? This becomes a critical issue because adverse outcomes were actually coming from older patients or chronic morbidity patients. And if you look at the proportion of participants who actually belong to these groups, you find for older age group, the proportion range from 10% to about 24%. When it comes to chronic morbidity, there were hardly any excepting Sputnik, which had almost 40% of the participants who had chronic morbidity per se. And therefore, we were unaware of how effective these vaccines would be when it comes to older participants per se. Now, one of the evidences that emerged about the older age groups, it tended to show from Israel that the odds of developing infection tend to increase, breakthrough infection tends to increase after 5 months over the less than 5 months after receiving the second dose. And that's classically shown to be increasing, but especially so among those who are older. And that's something which we have to keep at the back of mind, and a figure of 5 months. So essentially, what did it tell you? That our estimates of vaccine remaining protective perhaps doesn't hold true, because vaccines do not confer sterilizing immunity, and therefore you may still get the breakthrough infections. But what became more worrisome? In US, they are collecting data through what they call as COVIDNet. And in COVIDNet, they are trying to look at the breakthrough infections that are occurring in USA after vaccination. Now, about 164 million, that is about 16.5 crore people, have been fully vaccinated. Out of them, 7,000 odd people were hospitalized because of breakthrough infection. And of these, close to about 21% died out of those 7,000 lots. Of those who were hospitalized, 74%, 3/4 of them, were over 65 years of age. And when you look at variants, they were no different than the proportions or distribution that was seen in the national profile itself. So it essentially means we need to protect these older people, maybe with a third dose that you could perhaps think in terms of providing. So who should be, in essence, who should be considered to be eligible to receive the third dose? It could be transplant patients. It could be those who are having malignancies, especially solid lesions, as well as hematologic malignancies, and they are receiving treatment for the same. HIV infected individuals, severe primary immunodeficiency disorders, and those who are receiving high dose steroids for different chronic conditions, and elderly vaccine non-responders should also be considered as one who could receive a third dose. What is the impact? Now, Cox postulate would essentially tell you that theoretical basis for the same sounds better, but then the proof is going to come through the Cox postulate, where you have to actually show that if you provide third dose, does it reduce hospitalization? If you look at Israel's data, in August, they started providing third dose to individuals, and there they realized that when they provided third dose to people, there was a dramatic drop in hospitalization that was observed in Israel. So one of the issues that tends to come to one's own mind, because all of us are doctors, should it be given to healthcare workers or frontline workers? There is no evidence to this effect. Most of us tend to believe that perhaps our risk of exposure continues to be high, but still, if there is no evidence, there is no reason to worry, especially because we know that even if there is a breakthrough infection, this infection is more likely to be mild and asymptomatic, and you can still prevent it efficiently using COVID appropriate behavior as well as PPEs during your functioning. Now, which are the countries that have approved the third dose to the priority groups that in general we try to look at? Every country has a different approach. For example, in France, they added it to the older age group population, that the third dose has to be given. Now, you suddenly start realizing the entire movement started in the month of April, and now there are 5 major developed countries which have decided to provide third dose to population sets which may be differing in small proportion of these criteria related to immunosuppression per se. So France, UK, Israel, and Germany, and on Friday, even US FDA has approved third dose to be provided to those who are immunocompromised. Can one receive different vaccines as 2 different dosages? Still not in India. What we must remember that interchangeability trials have not yet been done in India. And theoretically, if somebody asks you a question, heterologous vaccine, which comes from different platforms, are likely to work better because there is an increase in immunogenicity, which should be expected theoretically. Now, is there some evidence today? If you look at the accidental mixing of vaccines that occurred in UP, there were 18 odd cases which were studied by NIB, where they tried to evaluate the heterologous immunogenicity, and they found that the vaccines, even if they were mixed up, they were safe and they had better immunogenicity when people used heterologous vaccine over those who were homologous. But can we extrapolate the whole thing? This is a very small study, and as I said, there are always concerns when you mix up lab studies and take them straight away to human beings for recommendations per se. What we don't know, there are certain things, certain questions which we will have to reflect upon. Now, if you think in terms of platforms and the vaccine platforms that are available currently, if you are to provide third dose, should that third dose be from the prior vaccine itself is a question which we will have to decide. Perhaps it may not remain relevant for ZyCoV-D, which as DNA vaccine is likely to have lower efficacy figure, and therefore they are already talking in terms of providing 3-dose vaccine. If you look at the third dose could also come from a similar vaccine platform. No, you could perhaps replace the mRNA by Pfizer and Moderna, depending on its availability. When it comes to us, we could use Covishield or J&J's vaccine. Both of them are adenovirus-based vaccine. Especially, both of them tend to rely on adenovirus 26 as the vector. Covishield, with 1 or 2 dosages of Sputnik V, we still don't know, because the first dose is adenovirus 26 and the second dose tends to come from adenovirus 5. We don't know what would be advantageous for us. should that adenovirus vector be, or should also be different than the vector that is used in Covishield? These are unanswered issues. Should we be using different vaccine platform? That is, you are using adenovirus-based vaccine, and then you are adding a whole inactivated vaccine as Covaxin. We still don't know those parts as of now. Would third dose, no, if we were to propagate third dose, would this increase side effects per se? What is the evidence that is available today? No, we will look at the evidences related to AstraZeneca at this juncture. No, in immunocompetent hosts, no, what was it that they found? That these did not increase the adverse events that tend to occur immediately after vaccine administration. But one must remember that the second dose, the third dose, the first two dosages came from mRNA vaccine here only, and then they had added this adenovirus-based vaccine. When it comes to the adverse events profile for third dose among immunosuppressed, now those who were receiving maintenance hemodialysis, does it differ? No, most of them had mild to moderate symptom. They were similar to their prior experience when they received first two dosages, and none of them required hospitalization. But there is one concern. When you use adenovirus-based vaccine, there is a risk of development of vaccine-induced immune thrombocytopenia. Though the proportion of people who may develop that appears as small, this tends to occur more among the younger population, which may not fit classically into those who would require third dose as of now, but it could perhaps be provided to those who have history of receipt of heparin. But that remains as a concern, that if I provide different platforms dosages, now one concern would be, would it bring in same toxicity, especially one that is related to adenovirus, as one of the risk profiles for every such person? Will it cause antibody dependent enhancement? That's something which is more worrisome. It's a dreaded complication that has been seen in the past with dengue and RSV vaccines. If you actually look at animal data that has emerged so far, no, people have observed that it tends to occur in mouse and ferrets, even for this SARS-CoV-2. And what is also important is, if you are using certain platforms, there is a scare in animal studies that has been induced because of the findings that emerged, that whole inactivated vaccine, VLP, that is virus-like particle, and DNA vaccines may lead to antibody-dependent enhancement, though it has still not been confirmed in human studies. And so far, so many vaccine dosages have been given. There are very few, if at all. No, it's a very, very rare kind of event that there are perhaps only 2 odd instances where ADEs have been reported in patients who have received the vaccine. So it's likely to be a very rare phenomena. But once you mix those vaccines, the issue will suddenly come up that, the ADE tends to occur because of non-neutralizing antibodies. So if I'm going to mix the whole inactivated vaccine with a vaccine that is usually a spike protein based vaccine, whether it is adenovirus or whichever way as vector, no, one thing which we have to realize, that non-neutralizing antibodies may increase, and therefore antibody dependent enhancement is likely to occur as a theoretical possibility. We may have to wait for some time to get the evidence on the same, because no other country is using such a mix. Whether it is UK, they're not using whole inactivated vaccine, so we don't know what might happen. Now, would it raise certain operational issues? It will help us in rollout if the vaccine dosages are in plenty, but then availability of dosages may suddenly become an issue of scalability of production. Now, you might find that if I go for interchangeability, Covaxin, you cannot produce large number of dosages. Sputnik V, second dose, we are already struggling. Even Gamelia is also struggling. Zycov-D, the numbers that they can provide are also going to be small. If everybody seeks mixed dosages, then supplies will become a challenge. The interval between two dosages after the first dose, we do not know what should be taken as classic interval. No, whether for Covishield you will still give 16 weeks time and then provide Covaxin, or if you are providing Covaxin, will you only provide 4 weeks time before giving Covishield as a vaccine? Should the third dose come from the vaccine dose that is developed for the most recent predominant variant of concern? There are certain worries that are there as of now. One of the vaccines called as CureVac was developed by Merck, and when they looked at their efficacy after completing the phase 3 trial, they found that the efficacy was only about 47%. And that was a shock. They had to drop this particular vaccine trial, but they tried to find out why did they have so low efficacy? Because efficacy by and large for other vaccines has been so high that it was unacceptable. When they looked at it, they found that majority of the infections that were occurring because of variants. Almost 99% of the infections were from the variants per se. Now, one of the issues that tends to come up is, would geographies and admixture of variants, would they rule the type of vaccine that you may have to use, given the variants are likely to impact the vaccine efficacy per se? And as Ira was referring to, that we may have to think in terms of regulatory changes that may have to be brought out. There may be, should we be accepting bridging studies and allow those to be marketed, or would you like to have efficacy studies if that particular variant is seen only in your own country and the vaccine was developed on a different strain, different variant per se? Now, one of the issues that emerges is there is a fear that are manufacturers or researchers looking at mixing these vaccines or the third dose per se? Yes, they are. If you look at heterologous boost, there are multiple researchers who are trying different permutations and combinations and trying to find out the impact on safety as well as efficacy. When it comes to homologous boost, all of us know that Covaxin's trial of third dose that has to be given after second dose, after 6 months after the second dose, is continuing as of now, and perhaps we should know the results coming out from them. Vaccine dose based on variants, Moderna and Pfizer, they are trying to make efforts to try to use newer variants that have come in to develop a vaccine dose, and perhaps we will know by next month end that whether that has been a successful attempt per se. But what is more worrisome, if you approve third dose, one needs to keep your eye on vaccine rollout inequity. Now, if you look at globally, there are 462 crore vaccine dosages which have been administered. They are increasing every day by more than 3.5 crore dosages. Now, if you look at how many people have received at least one dose of vaccine, it comes to almost a third of the population globally. But you try to look at the details, then you suddenly start realizing that less developed countries' coverage is only 1.2%. And why does this become important? This becomes important because those countries are going to get infections more often and more severe that could occur there. And if that starts happening, perhaps there would be a boost for this virus to mutate more, because it's going to replicate into human bodies more often and develop variants which could perhaps pose a threat to other countries who are otherwise vaccinated. This vaccine inequity is far more a botheration, because high-income countries, they are getting vaccinated 20 times faster than low-income countries. And now if you add the third dose, then it will also ensure that these poorer countries will not receive this vaccine dose as a public health issue per se. At this particular rate, perhaps we may require 6 months to vaccinate everybody if vaccine dosages remain available across the world. But one must also remember, if we add a third dose, where will we go based on the current calculations? In short, immune response tends to wane off in certain immunocompromised groups, the older individuals, especially at 5 months, after responders, to the 2 dosages per se among those who are vaccine responders. Variants reduce the vaccine efficacy. Heterologous 2 dosages are likely to be immunogenic and safe, but recommending 3rd dose can pose a challenge to cover vaccine divide. Thank you.
Thank you very much, sir. Now I hand over the platform to our panelist.
Sir, namaskar.
Namaste, madam.
So in fact, this is my 3rd panel discussion. I have been listening to you over IIPS, so at least on this occasion, I happen to meet you. So thank you, sir. And in fact, I remember in the IIPS at that time, first wave was going down, and you pointed out that the road is not yet over because there is a race against the virus. So when that happened, the 2nd wave came after 2 months. So I still remember that. And I agree with you, sir, that vaccine inequity, particularly if we allow, once the vaccination rate goes up in any country, the unvaccinated become more vulnerable and they will be the harboring for the for the virus to mutate. And because the virus will get enough immune pressure to mutate. And then that cycle never ends. It will lead to a never-ending vicious cycle going on and on. So how do we plan out in terms of looking at the risk and benefit of 3rd dose is very, very important. So you have really, because everybody is asking, should we take a booster? Should we take a booster? Because here we think of individual interest. But when you look at the broader picture of public health, then comes a matter of question of equity and versus making vaccine accessible to each one, so that it's for the betterment of the whole global population. So I think there is so many questions have come. Madam, Madam,
Actually, the 3rd dose is very, very important, as you have rightly pointed out, for the greater interest of public health. All should get vaccinated. But it is seen that after 5 months, 6 months, we are losing the immunity against infection. It is seen, whatever we are observing. So 3rd dose, though it is required for greater interest, you have to vaccinate the whole population. That is what is a challenge.
I'm sorry,
it is a
madam,
challenge.
I could just add something. Perhaps I forgot to write it in the slides. No, it's not so simple as it appears. No, if you recall, for AstraZeneca, they chose the adenovirus vector, which came from chimpanzees, because you don't have antibodies against a virus that doesn't infect you. Same is true with adenovirus 5, which was chosen by Sputnik, and adenovirus 26, which was also chosen at that juncture. No, they don't cause human infection. Now, if you take 3rd dose, what will happen? What they were trying to avoid is presence of antibody, which is likely to impact the immunogenicity of that vaccine. So what I do is, instead of 2 dosages, now I mix the dosages and take the 3rd dose. What will happen? Perhaps I will not be able to use adenovirus-based vaccine, or I may have to choose another adenovirus vector, which has hitherto not bothered human beings. And that's going to be a bigger challenge, because 1/5 of these infections from adenovirus, 1/5 of these cases, common cold cases, may have adenovirus infection.
So there is one question in the chat box, why the data on Covaxin is so limited when lots of people have received that?
I don't know why it is limited, but I think it's a good step that they have submitted this particular data, not only for publication, but also for WHO's review. I can understand people tend to have a worry whether our regulatory standards have been rigorous or not. But when WHO will provide you their opinion, perhaps all of us will accept that it's going to be a useful vaccine. There is no doubt on that. Because please remember that this is one vaccine, which is a whole inactivated vaccine, knowing fully well that infections are not stopped by this first generation vaccine. Perhaps if you are using whole inactivated virus, the protection is likely to be better off theoretically for protection against severe COVID disease, to my mind, and also against infections per se. But that data will perhaps emerge better when we will compare nasal co-vaccine dose versus the intramuscular dose that would become available, and the differences will be understood better.
Thank you, sir. Any questions from audience? Sir, I have a question, sir.
Yes, madam.
What's your take on third wave?
Everybody is asking that. Everybody is apprehensive.
I have consistently maintained one line from last 3 months. Your second wave itself is not over.
Exactly, it's lingering. I mean,
it is a optical illusion. I call it when I teach. It's an optical illusion. Just because today you don't feel uncomfortable when there are 40,000 new cases that are reported, because you had a peak of 4 lakh cases, more than 4 lakh cases. But the reality is, if you look at the first wave, you had 98,000 peak, and at 40,000 you were still sweating. So to me, your second wave is not gone. And I don't think we should be thinking in terms of national third wave. This is too large a country. The epidemic that is occurring within those states is too heterogeneous. So essentially what will happen, like what you are seeing currently for Kerala continues to add cases, but in places where the exposure has occurred, the drivers of the transmission, whether it is population density, mobility being higher, are deciding the risk of exposure. So you don't find so much of risk of exposure in rural areas, so they were spared in the first wave. And then they become more vulnerable in the second wave because they were the ones who were far more mobile and the perception of risk was fairly low. So you will find that there would be heterogeneity. I don't think there will be a national third wave at this time point, but I can be open to be corrected because the virus is smarter than me. So it is possible that it may generate a variant which can perhaps impact the entire epidemic curve. But that fear I will still not have until the time I find a new variant that is emerging everywhere. That's the reason why I showed a slide. Today's world, excepting Brazil, everywhere Delta variant is found in almost 90% cases at this juncture. Brazil, we may have to still worry a little bit at this juncture, but we have to wait and see. I think whether vaccinated or unvaccinated, we need to continue to follow COVID appropriate behavior. And that's the only answer to stop this infection.
Yes. Right. So Charita, what do you?
Thank you, sir. Despite of your busy schedule, sir being a member of National Task Force for COVID-19 and a member of NACO also, he has found out time. So thank you very much, sir. So now that we have talked about the variants of SARS-CoV-2 a lot, we know that since late December 2019, this SARS-CoV-2 is playing a havoc in in many countries of the world, and India is the third most severely affected country. And since its outbreak, the virus has been evolving and resulting in many variants like alpha, beta, delta, like that. And some of them have having increased transmissibility and increased lethality. And that is as per WHO and ICMR. So experts are monitoring these variants in the virus strain of COVID-19 in India through INSACOG. So now we will listen to Dr. V. Ravi, who is now the nodal officer for genomic sequencing of SARS-CoV-2 for Government of Karnataka regarding the evolution of SARS-CoV-2. Sir, over to you, sir.
Thank you, Dr. Sucharita, and let me thank the organizers for giving me this opportunity to speak to you. My profound apologies for changing the program in the last minute. The Chief Minister of Karnataka suddenly decided to have a meeting at 4 this evening. So I had requested Sucharita to shift my talk to the end. In a way, it is good because a lot has been said. So I will try to keep it crisp as it is very late in the evening. And I must also say that it's always very difficult to speak after Dr. Raman Ganga Kedkar, who is a dear friend for the last 30 years. We worked in HIV together and are working in SARS-CoV-2 again now. So what I will do is give you an introduction on the virus, the evolution of the virus, especially the variants, why they emerge, how do you detect them, what is the current status globally, and what are the implications. I think a lot has been said, but I will try to give a different perspective. We know coronaviruses for the last 60 years. They are RNA viruses. They are enveloped. They are widely distributed in the universe in humans, mammals, and birds. Prior to the advent of the SARS-CoV-2, which came in late 2019, we had 6 human coronaviruses, 4 of them causing very mild infections, common cold-like or mild gastroenteritis. The first severe one came in 2002-2003, which is called SARS at that time. Now it's called SARS-CoV-1. And the second one emerged in 2012 in the Middle Eastern region, known as Middle Eastern region respiratory syndrome coronavirus. They exhibit genetic diversity, and because of increasing human-animal contact, they cause spillover events. Now, this is something very, very reminiscent of influenza viruses as well. Wherever there is human crowding along with animals and mammals, spillover events occur. And the human coronaviruses that cause infections have been spillover from 2 reservoirs. One is bats and the other is rodents. The severe respiratory coronaviruses are spillover events from bats. Their nearest cousins are found in bats. SARS-CoV-2 is presumed to have a spillover event from bats to civet cat, whereas the MERS coronaviruses was a spillover from bats to camels in the Middle Eastern region. And the current one, it is presumed that it is a spillover from bats to pangolins, which is an anteater. Incidentally, bats and pangolins were also sold in the Wuhan wet market, where there was a lot of crowding, and that's where the first case 0 or the ground index case was first reported. The spillover of from rodents as reservoirs occurs for the milder coronaviruses, which cause very mild symptoms. The structure per se, it is an enveloped virus, and embedded in the envelope is the most important protein, which we have all been talking for the last 3 hours, the spike protein, which is endowed with 2 important properties. A, attachment to cells. B, protection. Because if you can develop antibodies against the spike protein, you can prevent the attachment to viral to susceptible cells. Also embedded in the envelope is the membrane protein and envelope protein. Very little attention has been paid to these proteins. You know, sometimes in science, we tend to chase one goose. There are other geese also that are important. Only now, and of course, the third protein that is important is the nucleoprotein. It's a protein that protects the genome. It forms the capsid of the virus. So these are the proteins Apart from these, you have a lot of non-structural proteins. People are still trying to understand the functions of non-structural proteins. And we do know that many of these non-structural proteins do have an impact on both innate immune responses as well as acquired immune responses. And large part of them actually modulate the secretion of cytokines. And that's something, again, that is not attended to much in our research. Of course, the most important portion of the spike protein is the receptor binding domain that attaches to the ACE2 receptors, which is the receptor for coronavirus. The genome itself measures approximately 30,000 nucleotides in length. It's a it's a positive standard genome, meaning if you introduce the RNA into cells, if you can inject it or deliver it inside, it immediately goes into translation. So it is a positive standard genome. It's a single open reading frame. It codes for many proteins, two large proteins of open reading frame 1A and 1B. And then, of course, the structural proteins like the spike protein, the membrane, the envelope, and the nucleocapsid protein. The coronaviruses themselves are classified based on their genetic information as well as their biology, largely based on the gene sequences into four species: the alpha, beta, gamma, and delta coronaviruses. Human beings are affected predominantly by the beta coronaviruses, which has all the three severe acute respiratory syndrome viruses and two of the minor ones, and also a bat virus known as RATG13. Remember this because this is very important for evolution. Whereas the alpha coronaviruses have the NL63 and 229E, which cause mild symptoms in human beings as the members. The gamma and the delta do not have any viruses that cause infections in humans. Coronaviruses, because they are RNA viruses, we know RNA viruses mutate. We knew always that coronaviruses also mutate. They had the potential to mutate. But in the last 1.5 years, a lot of attention has been paid to recombination. Now, what is recombination? Some segments of the nucleic acid can combine when two viruses infect a single cell. This is what happens in influenza. It happens very efficiently in influenza because influenza has 8 segments of nucleic acid. It is not a single thread of genetic material. It has 8 different sets. So when a cell gets infected with 2 different viruses, recombination is one of the reasons that new variants emerge. Even in coronaviruses, we know now that there are 4 regions that recombination has been very nicely studied. One is in the ORF1b region. The second is in the second and the third, R2 and R3 are in the spike region, and the fourth is in the nucleocapsid region. Now, recombination has been shown between the parent bat virus, which is called the RATG13. RA actually stands for the species of the bat. I won't go into details. So from there is where this SARS-CoV-2 evolved. And recombinations have been seen more often in the regions of R2 and R3, especially between the bat and the human and the pangolin viruses. So it is believed that this is what probably led to spillover elements. In fact, when you look at the phylogenetic tree of human SARS-CoV, the SARS-CoVs, along with the bat SARS, the coronaviruses, you will see that the novel human coronavirus had a very, very close in the tree, a very closely placed next to the bat coronavirus. And It is the RATG13 that is considered the forefather from where the human coronavirus SARS-CoV-2 evolved. I'm not going into dwell into the controversy of whether the SARS-CoV-2 is a natural evolutionary element or whether it's a lab leak theory. I think the jury is still out on that. What we do know is that the bat RATG13 virus was being handled in many labs since 2013. So whether it's a spillover or whether it emerged as a spillover, whether it's a leak from a lab or whether it's a spillover in Wuhan market, I think it's going to be very difficult to conclude on that. But these discussions will continue and probably it's important they should continue. Okay, moving on to variants. A lot has been talked about this evening by my predecessors. Let me give you a crisp perspective on variants. The SARS-CoV-2, much to the surprise, as Dr. Ganga Kedkar, much to the surprise of all of us, turned out to be a virus that mutates much more than what we expected. There are two reasons for it. One is the scale of multiplication, the number of infections it caused. So naturally, we are seeing more mutations. And secondly, itself, there are many other reasons why variants have emerged. Now, this is a graphic to show you along the genome of the virus, the entire 29,903 nucleotides. Between December and April, there have been more than 4,400 variants that have emerged. Now, why do variants emerge? And before I go into variants, there was a lot of confusion, and I think WHO did a wise thing by giving very simple names. There was a lot of confusion on what to call variants. The earlier classification, there are a number of classifications earlier, and in Nature Microbiology, middle of last year, there was a very nice article which actually raised this issue and said that there are too many names being given. The storehouse of genomes currently is the GISAID. GISAID stands for Global Initiative on Sharing All Influenza Data, which is an initiative that was started in 2007 and subsequently being now used for genomes of many viruses, and SARS-CoV used this platform. So there are many different types of classification people were using. And one of the most popular classifications that was being used was the pangolin software. It's nothing to do with the animal pangolin. And this pangolin software classified the virus in alphabets as A, B, and C. And within A and B, there were sublineages. For example, when there was there were some significant mutations, B was classified as B.1 and then subsequently as B.1.1 and so on and so forth. But then this was getting too complicated. So I think the WHO stepped in and then simplified the classification, which I will come to shortly. Now, why do variants emerge? Dr. Ganga Kedkar very beautifully told you that one of the major reasons why variants emerge is because of pressure. One could be pressure in the terms of drugs, but we do not have very effective SARS-CoV-2 specific drugs. We do have drugs that have been repurposed, but they can put pressure. But the most important reason is it's inherent for RNA viruses to mutate because the enzyme, RNA-dependent RNA polymerase that copies the virus genome is a lousy enzyme. It lacks proofreading ability. That's why all RNA viruses mutate. And mutations can either result in a change in the genetic code, and that can result in a change in amino acid that may be synonymous or non-synonymous. To put it in plain language, a mutation can change virus three-dimensional structure if there is a significant change in amino acid. And that can make the virus more fit, which means it will survive. It will replace all the weak ones that bind to host cells. They will fall by the wayside, and the newer ones, and it's the survival of the fittest. So inherent to the virus is the property of mutation. And of course, immunological pressure, both in terms of immunocompromised people having long duration of infection, as well as some amount of immune pressure induced by vaccination, can also produce viral variants. In fact, the hypothesis on the emergence of the first variant of concern detected in UK late last year was that a person was treated, an immunocompromised person had infection for a long time, and on top of that, he received also passive immunotherapy. Now, moving on to the simplification of classification, the viruses are now called by Greek alphabets, and they have been classified as alpha based on when they were detected first, and alpha, beta, gamma, delta, which stand for the original UK, South African, Brazil, and the Indian variant. Now, you should also remember that variants are also classified into two categories: variants of concern and variants of interest. What is the difference? The variant of concern is one where they have shown extensive spread across the globe, more infectivity in the lab in cell culture experiments, and also probably changes in the clinical phenotype of the disease presentation, or there is enough evidence to say that vaccines are not 100% efficacious like with the parent Wuhan virus when they were developed. So these 3 points make up a variant as variant of concern. Currently, there are only 4: alpha, beta, gamma, and delta. A variant interest, on the other hand, we have at least 7: epsilon, zeta, eta, theta, iota, kappa, and lambda. And these are viruses that have shown a propensity to spread locally in certain communities, but they have not caused widespread, and they are still under investigation in terms their infectivity in cell culture. So they are classified as variants of interest. Now, the current variants circulating globally, I think all of you are very familiar. Delta has completely replaced most of the other variants in almost all countries. It is now detected close to 100 countries, more than 100 countries, and it is the predominant variant both in developed and developing nations. This is the current variant list in terms of geography, and I think most, as you can see, most of these variants are global, be it alpha, beta, gamma, or delta, and delta is the predominant one. There was a lot of hue and cry on delta plus, which is basically has the mutations what a delta variant has, but has an additional mutation in amino acid at position 417, and which is a mutation that was seen in the South African and the Brazil variants. Now that was also detected in the delta. So there was a lot of hue and cry. It's going to be more infectious, but thank God it actually did not spread widely as it was expected to. In my opinion, it should actually be called delta minus and not delta plus. Okay. There are two new variants of interest which are posing a bit of worry. And one of them is the lambda variant. And recently, the Japanese published a paper that it is very highly infectious. In fact, the Japanese claim that it is more infectious than the delta. And it has been spreading. It was first detected in Peru and then spread to a lot of South American countries, but it's now also seen in the Eastern Hemisphere in Japan. And this spread has been a little fast. So we have to wait and see. And also it has certain mutations that have shown, at least in vitro, that the vaccine antibodies against conventional vaccines, first generation vaccines, are not completely neutralizing this variant. So we'll have to wait and watch whether this is going to spread and it's going to take over. The other variant is, of course, Kappa. But Kappa, we had seen a lot of it in India in the first 3 months of this year. But it is an infectious virus, but nothing to worry. It is not as infectious as the Delta, and it is not as evasive as the Delta is. So Kappa may not pose a problem, but Lambda may pose a problem. It is important to continue to detect variants. Indian government has initiated a consortium of labs known as INSACOG, Indian SARS-CoV-2 Genomics Consortium, and it started off with 10 labs. Now it has 28 labs, and there's a separate website. Those of you who are interested can go and look at the kind of activity that it is doing. Basically, it was set up to assess, to detect new variants entering the country or emerging within the country, and to determine whether these genomic variants are variants of interest, they are responsible for huge spread, and also to establish a systematic surveillance platform so that we continuously keep sequencing genomes. The INSACOG has sequenced close to a large number of genomes now, more than 60 to 70,000 genomes. Genomic sequencing is not a simple technology. It requires expertise, and it's time consuming, and it's resource intensive. Results take a minimum of 1 week after the sample is received in the lab. It can take from 1 to 2 weeks. So it is not required to be done in every positive case, and it cannot be done because the CT values of samples have to be less than 25. India is using the WHO framework for sentinel surveillance. Basically, it has set up 10 to 20 sites in each state, and from each site, 15 samples are collected every 15 days. And these 15 samples are mainly collected from international travelers, representative samples from focal clusters and outbreaks, cases of COVID-19 reinfection, infection breakthrough infections, any clinical phenotype change in terms of morbidity, mortality, and of course, pediatric COVID-19 cases. INSACOG's contribution globally has been the detection of Delta variant, and this is a map that is showing you on the x-axis the time, and the y-axis the percentage of variants, and you can see between December and 12th May, Delta variant was detected in India, and it took over completely. Variants also have a lot of implications in terms of spread. Here are maps showing you how the UK variant started late in last year and spread across quickly to many countries across the globe, including India. We have been tracking genomic epidemiology of SARS-CoV-2 in Karnataka. Middle of last year, we did some studies in May during the lockdown and showed that there were a large number of lineages circulating. And one of the major lineages that was circulating, which I forgot to mention, I'll go back and tell you, I call it the grandmother variant. And that is the first mutation noticed late February and early March in Italy, reported from Italy, was a very significant change in amino acid at 614 position on the spike protein from an aspartic acid, which is represented as D, to glycine. D614G is the mutant. Now, what is the importance of this mutant? Very soon, within a matter of 8 to 12 weeks, globally, D614 took over, and almost every country was reporting. Now, on this grandmother mutant backbone is where all the other variants are emerging. So that's something I forgot to mention. So I think that is very important to remember that one of the major implications for And we had detected D614G in our May samples in a small proportion. Recently, we redid post the arrival of mutants, and we did find that we had the UK variant, and we had the Delta variant, and we also had another lineage which were predominated for 1 month and died down, and that is B.1.36.29, which was infectious for some time, but it did not sustain itself with the advent of a Delta variant. Now, other implication, there was some talk before me on virulence, and there is not much evidence to say. When you say virulence, you should remember virulence means by definition increased severity of disease. There are no robust studies to say that the virulence of a particular variant is more than the others. There have been isolated reports of the South African, the Brazilian, and the UK variant saying it is more virulent. When you have large spread, then you have more number of severe cases proportionately. That does not mean the virus is more virulent. There are isolated reports saying that there are some changes in virulence of the viruses. Antigenicity, I won't go into details because a lot has been talked about by Dr. Ganga Ketkar and Dr. Ira Praharaj, only to say that before you call a variant as a variant of concern, you need to show in cell culture, grow the virus, compare it with respect to the parent Wuhan strain or the grandmother D614G mutant, and show that the virus is the amount of virus produced for the same dose into cell culture is much more, which means there'll be a shift to the right in these graphs because the scale on the x-axis is in terms of the logs. So if it moves to the right, that means it's a more replicating virus, and you can see both the UK variant, which is signified by the signature mutation of 501N to Y change, and the Delta variant, which is L454 to R wave, are more infectious in cell culture as well. And vaccine efficacies, a lot has been talked. I won't go into details. I must say that the consequences of emerging variants, to summarize for you, is faster spread. There was some concern about ability to evade a diagnostic tests, but let me tell you, most of the tests that are used today, the PCRs globally, do not focus on one gene. They are multiplex assays, and not in India at least, the spike protein based RT-PCRs we use are very, very less. We are so better off because we use tests that multiplex usually the RDRP, the N, and the envelope gene, very few with spike. And since it's multiple genes, the chances of missing variants is relatively less. So that is not a major concern. And the ICMR has started an exercise, desktop exercise, and part of that, looking at continuously the new kits that come, whether they will be able to detect. We can do some bioinformatics and say whether they detect or not. Evasion of immunity has been talked about. I won't go into details. To summarize then, molecular evolutionary analysis has shown that SARS-CoV-2 originated from non-human mammals, mainly bats. The SARS-CoV-2 is a mutating virus, and there is also evidence to say it is recombining. There's recombination, so new variants will continue to emerge, and there is absolutely no way to stop it. We need to have constant surveillance to detect the variants. That is the only way forward. And available evidence indicates that this is a point already made, that the current vaccines are able to afford protection against variants, albeit to a lesser extent. So one should remember that we are still lucky that severe disease and death is not greatly impacted by emergence of variants, but I don't know how long we'll hold on. Thank you very much.
Now, the esteemed panelists can have a discussion with them.
Thank you, sir. And I would first request the audience, if they have any they have put any questions in the chat box, I cannot see. Okay, sir, I just wanted to find, I just for my own curiosity, because we are also a member of the INSACOG. So how prudently or how optimally we should think of sampling for sequencing? Because 15 and from each side 15, so I just wanted to find out how should we do an optimal sampling so that at least we get the right information at the right time.
See, the WHO framework is a guideline. You look at UK, they have the resources and they have the capacity and they have the network. So they are doing 10,000 genomes a day. Is so much required? The answer is no. Merely by doing first of all, we should understand what is the purpose of sequencing. The purpose of sequencing is to detect emergence of new variants. India has done beautifully well, in my opinion, because our contribution is 1/4 to the world. One variant of concern was detected here. So I am very happy with what is happening. But if you look at the public discourse and including some of the experts, everybody wants every sample to be sequenced. It's rubbish and it's a waste of resources. Right now, the second wave has come down. So the number of samples have become a challenge, even for 5% in many states. So what is more important is to strategize in what we are doing in INSACOG. You know, you are a member of INSACOG and so am I as an advisory group member. It's to be very strategic. It's 15 samples is a guideline, but I'm sure you don't have to stick to 15 samples, and it has to be dynamic. You cannot have a rigid rule. Wherever there is a cluster, we should focus. Wherever there are breakthroughs, we should focus. Wherever there's a new clinical phenotype, different phenotype, or the phenotype is changing from mild to severe, we should, if we do that, I'm sure we will be tracked. Of course, we need more labs because we are a huge country. And we need to probably reduce the time taken for sequencing. We are taking slightly longer than many other countries. I'll stop you.
Madam, apna kon koibe? Ramla madam.
What is more important is that finding of new variants or the transmissibility, which is very, very important. If you find out a new variant, the most important thing is that you have to find out what is their capacity to transmit, because we have got such a populated, highly populated country, and people are sitting at home. They are not able to move, most of them. And it is very, very difficult. I am telling it from the public viewpoint, because that is what is more important, but we cannot just predict or say which variant is more transmissible and which is not. If at all it is more transmissible, what is the next step we can take?
I entirely agree with you. And for determining higher transmissibility, the most important is the quality of data we collect. And that is a big challenge, I must admit. We are still groping with that challenge. Although now the matrix has been finalized, but for the older samples, it's a huge challenge to go back and get that data. Prospectively, at least, we are collecting much better data in INSACOG in terms of the details of the patient, in terms of clinical details, contacts, and the number of infections that have occurred from this particular sequenced genome patient. So these things are very important. You very rightly said that determining transmissibility is important. Now that has to come predominantly from the field, that is the epidemiological data, and this sample has to be sent to nearest lab where it can be isolated and the cell culture experiments can be completed quickly. Now we are doing it, but we could do it at a much faster pace, and our quality of data can definitely be better.
Thank you, sir. Thank you very much. A lot of work we are doing for our country. Is still developing. Still, we have gone a lot ahead.
Yes.
But problem for public interest is that people are really very much perturbed. So the daily roji roti is also being affected.
Madam, one point I want to make, sorry for being so blunt, variants or no variants, I would underscore
Yes.
what Dr. Raman Ganga Ketkar very beautifully said.
Yes.
No variant penetrates a mask much more than any other variant.
Yes.
Wearing mask is important. Maintaining social distance.
Yes, that you have to maintain.
I know we know a lot about the virus. I mean, if Raman is there, he will definitely agree with me. We know a lot about the virus. We know a lot about the mutations. We know a lot about the
Yes, yes.
we don't know, we are
What to
very
do.
poor at human behavior. I come from Nimhans, and I can tell you this. I used to say this in HIV. I'm repeating it again. Human behavior is the biggest variable.
Everyone should be responsible.
And the greatest challenge, sir, and the most
Greatest challenge.
challenging is to change human behavior. It's very easy to say IC, information, education, and communication, but it never works in real life.
Exactly.
People don't understand the importance.
It's very difficult. The most
Very
difficult thing to change is human behavior.
Exactly.
Everyone has to be responsible. Okay, thank you very much, sir. So nice presentations. Thank you, Sucharita. Thank you, Sangamitra.
Thank you, ma'am. Thank you, Sucharita. And
now I hand over the platform to our Associate Professor, Dr. Rajkumari Rathod, to give the vote of thanks. Rajkumari, please.
Yeah, thank you, ma'am. So a very good evening to all. It's my privilege to propose a vote of thanks in this occasion. I hope you all had a very nice evening today. So I, on behalf of the Department of Biochemistry, BBMCH, first of all, I extend my most sincere thanks to Almighty God for making today's occasion resounding success. And next, on behalf, I extend my heartfelt thanks to our speakers for sparing their most valuable time from their busiest schedule to grace this CME, and also for enlightening us with their commendable talk and sharing of your finding, knowledge, and opinion on this novel topic. Now, I would like to thanks to Dr. V. Rabi sir for his very nice explanation and talk on evaluation of SARS-CoV-2. And next, I'm very thankful to Dr. Satyajit Rath sir for focusing the light on the how immune system responses in COVID-19. The next, I also like to extend my thanks to Dr. Rachitananda ma'am for a very nice explanation of the biodirectional relationship of this COVID-19 and diabetes mellitus. Next, I'm extremely thankful to Dr. Ira Praharaj ma'am for enriching us with the various types of the vaccine and the various technology and their mechanism of action. And I'm very thankful to Padam Shri Dr. R. Ganga Ketkar sir for the very informative talk and making us more understand about the vaccine. Now, I also would like to express my humble thanks to our panelists, Dr. Pramila Mishra ma'am, Dr. Sangamitra Pati ma'am, for being with us. You have provided us with the valuable support in enriching the CME program. Thank you, ma'am. Next, I also wish to express my gratitude to our Dean, Professor Dr. Savita Mahapatra ma'am, for giving us an opportunity to conduct this virtual CME program. And we are also very thankful to the madam for providing the encouragement, the guidance, and a huge support at all the time. So as we know, and any event of this dimension cannot happen though overnight. It requires a meticulous programming, planning, and the execution. So I would like to thanks to the person behind this, our moderator, Dr. Sucharita Mohanty ma'am, for her valuable effort to coordinate with all the speakers and panelists and for the smooth organization of this CME. I also would like to thanks to Dr. Chinmay Mahapatra sir for his minute-to-minute guidance and the support so we could conduct this virtual CME program. And as we know, no program can become successful with a single person. So I extend my thanks to our department for their support. And I also like to thanks to the participants for their active participation in this event. Once again, I would like to thanks to all the esteemed speakers, our panelists, and the participants for being with us in this evening. And it's been a great pleasure for us. Thank you so much.
Thank you.
Thank you.
Thank you, ma'am.
All of you, and a good
Thank
evening.
you, sir.
Good evening, sir.
Thank you. Congratulations, Sucharita.
Thank you, Sangamitra.